Hi guys, welcome back. So I think we are done with micro revision and now we will start with medicine. I hope I'm audible and loud and clear. So in next 3 to 4 hours, we will try to quickly revise the cream of medicine. Of course, medicine is very vast and I cannot cover everything in the time available. But the most important things we will try to cover, right? So I will not waste time. I will directly start with the topic. You might be having the workbook with you. So if you want, you can make the notes along with me. If you don't feel comfortable making the notes right now, then this will be shared with you and you can go through that as well. Okay, so we'll start with cardiology. And in cardiology, the kind of questions are asked primarily from physio medicine integrated related to pulse, JVP. Every exam, there is a question on JVP, heart failure, valvular heart diseases. So we'll begin. Now we'll start first with the normal pulse waveform. You may be thinking why sir is talking about it, because you get some image based question where a pulse waveform is given and a part of that pulse waveform is highlighted and they will ask you what does this signify or which part of cardiac cycle this is relatable to, right? Okay, so pulse is a pressure wave. What is pulse? Pulse is a pressure wave. Means what? Pulse is not produced because of the flow of blood. It is because of the pressure created by the ejection of blood by the left ventricle into the aorta. So during the systole, in the left ventricle, there is some blood which we eject in systole into the aorta. So when we eject the blood into the aorta during systole, it triggers a pressure wave. The pressure wave travels along the wall of the aorta and eventually through the blood vessels. So this pressure wave is what we call as pulse. Usually pressure wave travels 20 times faster than the blood that is flowing in the blood vessels. So blood पीछे पीछे जा रहा है, pressure wave आगे आगे जाता है. So when you palpate for the pulse, what you feel is a pressure wave. The pressure wave coming and hitting your fingers, and it is not the blood which is coming and hitting your fingers. Now this waveform, when I plot it on a graph, as soon as I eject the blood from the left ventricle to aorta, the waveform is triggered. So pressure before the blood is ejected is at the bottom. As the blood gets ejected into the aorta, pressure starts rising. So the graph should start going up. So when you look at the pressure waveform, it kind of looks like this. So it has an initial upstroke. It is going up. This upstroke is because of the left ventricular ejection. This upstroke, right? We will call this upstroke as the percussion wave. We'll call it as percussion wave because I just put the blood into the aorta, percussed it and triggered a pressure wave. So we'll call it as percussion wave. So as the blood has come into it, a pressure wave is triggered. After this blood starts flowing and the pressure wave goes ahead. My mind expects that the graph now should start coming down because the pressure wave propagated forward and the pressure at the proximal region starts dropping down. But that's not exactly what happens. तो फिर होता क्या है? The Newton had said that for every action there is an equal and opposite reaction. So this aorta that was distended by the ejection of blood into it now will recoil. And when the aorta recoils back, the act of recoiling makes the aorta smaller. वो छोटा हो जाएगा, right? Blood eject किया, dilate हुआ, pressure wave trigger हुआ, जैसे ही aorta recoil करेगा तो aorta का diameter या volume कम होगा. And we are all familiar with the physics law called as Boyle's law, which says volume is inversely proportionate to pressure or vice versa. मतलब जैसे ही volume कम होगा तो pressure increase होगा. So now as aorta recoiled, the volume decreased, pressure increased. So the graph will further ascend up. So now we have second waveform. This second waveform, I will call it as tidal wave. It is tidal wave. After this, of course, pressure कम होने लगेगा, so the graph starts going down. But this is not going to perfectly go down to the baseline. जहाँ से start किया था वहाँ तक वापस नहीं जाएगा. It will start going up again. Now, what could be the reason for the pressure wave to start going up again? Because as I ejected the blood into the aorta and the pressure wave traveled through different branches of the aorta to all the peripheral tissues. Peripheral tissues also will follow the Newton's law, means they will also offer a resistance and reflect the wave back. So there will be recoil at the periphery level as well. So this phenomenon we will call it as peripheral vascular resistance. जैसे ये recoil होगा, diameter कम होगा, there will be increase in the pressure. So that gives rise to another graph rising up, and then इसके बाद में another graph rising up, and इसके बाद में it will eventually lower down to baseline, और फिर अगले systole में फिर से एक cycle ऐसा ही start होगा. So this waveform I will call this as, we will call it as dichrotic wave. Dichrotic wave. एंड ये जो कलेक्टिवली शुरू का दो वेव्स हैं, इनको मिला के हम कहेंगे एनाक्रोटिक वेव. सो pulse wave has an anacrotic wave and a dichrotic wave. Okay. नाउ अब आप बताओ इसका जो हाइट है, द पीक ऑफ दिस वेव फॉर्म किस पे डिपेंड करेगा? इट विल डिपेंड ऑन हाउ मच ब्लड आई एजेक्ट इनटू द aorta. The more blood I eject into the aorta, I will trigger a larger pressure wave. So the height of this wave will become taller, right? So can I say that the amount of blood that I eject into aorta is stroke volume, and stroke volume decides the peak of the pressure? Yes. And this peak pressure को हम कहते हैं systolic BP. So height of this pressure waveform, that itself anacrotic waveform, is the systolic BP. And जो dichrotic wave है उसका height है diastolic BP. That is the diastolic BP. So this corresponds to systolic BP, and this corresponds to diastolic BP. And you must be already knowing that the difference between the systolic and diastolic BP जो ये है इसको हम कहते हैं pulse pressure. We call it as pulse pressure. So now we will just write down the mechanisms behind these individual waves. That is what is asked in the MCQ. So percussion wave. What is the reason for percussion wave? The percussion wave is triggered by, it is due to left ventricular ejection of blood into aorta. Tidal wave is triggered by aortic recoil, aorta recoiling, aortic recoil. And the dichrotic wave is triggered by peripheral vascular resistance. Peripheral vascular resistance. And here, as I've already told you, percussion wave and tidal wave together we call it as anacrotic wave. Anacrotic wave. So आपके exam में they might give this pulse waveform, and then they may mark one of the structure, and then they will ask what is the event responsible for this particular waveform. So अगर वो tidal wave की तरफ point कर रहे हैं, so it is because of the recoil of the aorta. So if the arrow is pointing towards the percussion wave, it is because of the ejection of blood into the aorta by the left ventricle. If it is pointing towards dichrotic wave, it is because of the peripheral vascular resistance. Clear? Okay. Now many a time they also ask you some abnormal pulse forms and what conditions we can get it. Okay. So we'll first start with the bottom, pulsus parvus et tardus. Okay. Now here, pulsus parvus et tardus. What does that mean? It refers to slow rising and late peaking pulse. Slow rising, low amplitude. Amplitude मतलब height of the pulse. Low amplitude, late peaking pulse. Okay, समझाता हूँ. What does that mean? What does that mean? Small amplitude मतलब ये जो height of the pulse waveform है वो छोटा है, small है. क्यों छोटा होगा? जब stroke volume कम होगा तब ये छोटा होगा. Second, जब pulse start होता है वहां से peak तक पहुंचने के लिए एक time लगता है. This is taking longer time. So we are reaching the peak much late. This condition we call it as pulsus parvus et tardus. So for that you have to remember it is seen in, very important MCQ, seen in severe aortic stenosis. Severe aortic stenosis. Okay. Then we have another form of pulse called as pulsus et tardus. Here tardus means slow. So it is slow late peaking pulse. It is seen in left bundle branch block. Left bundle branch block. Then we have pulsus parvus, which refers to, parvus means small. So small amplitude or low volume pulse. Small amplitude or low volume pulse. Low volume pulse. Okay. So where do we see that? It is seen in aortic stenosis. So aortic stenosis, earlier stages you get pulsus parvus, but when it becomes more severe, you end up with pulsus parvus et tardus. Pulsus parvus et tardus. Okay. Then you have this pulsus bispherians. Normally, pulse mein, when you look at the pulse waveform, you have to also remember that this anacrotic wave is happening in the systole. So this is where you have the S2, this is where you have S1. Again, after this, you will have S1. So that means this is the systole and this is the diastole. So that is why the peak of the systolic waveform is what we have called it as SBP, systolic BP, and the peak of the diastolic waveform is what we have called as DBP or diastolic BP, right? So that means your percussion and tidal wave are part of systole and dicrotic wave is part of diastole. So in systole, how many peaks we are getting? Only one. But if I get two peaks in systole, then we call it as pulsus bispherians. Pulsus bispherians. It refers to two peaks in systole. Two peaks in systole. Very important MCQ point. Where do you get it? We see this kind of pulse. For the exam, most important cause you have to remember is hypertrophic obstructive cardiomyopathy, HOCM. You can also get it in patients with aortic regurgitation. These are the two important causes you have to remember for pulsus bispherians. Okay. Now pulsus paradoxus. Pulsus paradoxus. It's not a pulse per se. It's not the pulse per se. So what is it? So normally what happens during inspiration? During inspiration, systolic BP decreases. But if it decreasing more than 20 millimeters of mercury, then we call it as pulsus paradoxus. Normally up to 20 millimeters of per mercury drop hota hai. But if it is more than 20 millimeters of mercury decrease in systolic BP, it is called as pulsus paradoxus. Where is it seen? Seen in right heart failure, COPD, then asthma, and the list goes on. But just you have to remember that primarily think of right side of the heart when you think of pulsus paradoxus. Okay, so this is about the pulse. What you have to remember, I want you to primarily focus on the waveform, and if you say, sir, I can only remember one or two pulse conditions, then I want you to remember pulsus parvus et tardus for severe aortic stenosis and pulsus bispherians for HOCM. Why am I stressing on it? Because many a times this pulsus bispherians is given as a clue for the diagnosis of HOCM. Question में बहुत कुछ और pointers होंगे like young individual, developing ventricular tachycardia, banana shaped left ventricle, all those pointers. एक और pointer हो सकता है pulsus bispherians also. So you should be able to catch the clue and recognize that the examiner is talking about HOCM. Okay. So from the pulse, let's go to JVP. JVP is even more important than pulse because plenty of questions have been asked from the JVP. Almost every exam one question comes. So let's begin with the normal JVP waveform. So for the pulse, we have to look at the left side of the heart, left ventricle ejecting the blood into aorta. But for the JVP, we have to look at the right side of the heart. So let us say that this is my superior vena cava. This will be my right atrium. This is my inferior vena cava, and this is going to be the right ventricle, and the blood from the right ventricle will get ejected into pulmonary artery. So this is superior vena cava, this is inferior vena cava, this is right atrium, right ventricle, pulmonary artery. तो यहाँ पे I will have this tricuspid valve, यहाँ पे pulmonic valve. Okay. Now that the superior vena cava is perfectly aligned anatomically with the internal jugular vein, any pressure that changes in the right atrium will directly influence the pressure in the internal jugular vein. So that's why first thing we have to remember to understand the JVP is that the right atrial pressure, the internal jugular vein pressure, right? the jugular vein pressure, which is nothing but internal jugular vein pressure, is directly proportionate to right atrial pressure. So I can use it as a window to see what is happening with the right atrium. Whenever JVP increase, it means right atrial pressure is increased. Whenever JVP is decreased, it means right atrial pressure is decreased. Okay, so now in the cardiac cycle, we transfer the blood from atria to ventricle during ventricular diastole. During ventricular systole, we eject that blood to the concerned artery, pulmonary artery, right? So let us look at the diastole first. I have blood in the right atrium. I have to transfer this to ventricle. So to transfer that to ventricle, diastole में चलते हैं 3 phases. पहला है isovolumetric relaxation. उस time the tricuspid valve will be closed, pulmonic valve will be closed, and the ventricle relaxes passively. Means not passively, of course, actively, but with the all valves closed. So no transfer of the blood happens, but ventricular pressure decreases because it is relaxing. Relaxation means volume expanding. Volume expanding means pressure is going to decrease. So as the pressure decreases, the valves open. And once the valves open, the blood starts moving from right atrium to right ventricle because of the pressure difference. Right atria has blood, its pressure was high. Ventricle is empty, its pressure is low. So blood starts moving. कब तक मूव करेगा? जब तक दोनों चेंबर का प्रेशर इक्वलाइज हो जाएगा. As the blood starts moving from right atrium, its pressure starts decreasing, and the blood starts filling the right ventricle, its pressure starts increasing. At some point of time, both the pressures will become equalized. Till that time, the blood keeps moving passively. We will call it as passive filling. Once the passive filling is done, I may have still some amount of blood in the right atrium. To push that to the ventricle, right atrium actively contracts. This active contraction pushes the remaining amount of blood to the ventricle, and this phase we will call it as active filling. So let us think of the active filling. Active filling के time पे right atrium क्या कर रहा है? Contract कर रहा है. So when it is contracting, what is happening to its volume? Decreasing. And as we already know, there is Boyle's law, which says that the volume and pressure से share inverse relationship. तो जैसे ही volume decrease होने लगेगा, pressure increase होने लगेगा. So if I want to plot a graph of the pressure in the right atrium, starting at this point, means starting from the beginning of the active filling. So beginning of the active filling में pressure यहाँ पे था. During the active filling, atria started contracting. So pressure starts increasing. So my graph will start going up. This wave, I will call it as A wave. A wave. So in the JVP, we will have an A wave, which is due to atrial contraction, and it corresponds to which phase of cardiac cycle? It is due to atrial contraction. Atrial contraction happens during active filling phase of cardiac cycle. So this corresponds to active filling phase of cardiac cycle, which is a phase of diastole. Which is a phase of diastole. Okay. Then after the A wave, the atrial active filling is complete. Atria goes into relaxation. So before that, the tricuspid valve has to close, right? So that the ventricle going into systole does not cause regurgitation of blood. So there will be closure of this tricuspid valve after the A wave, which produces the sound S1. Okay. After that, ventricle has received the blood. Ventricle will go into systole. Atria will get into diastole. So as the atria gets into diastole, it starts relaxing. So as the atria starts relaxing, the pressure, the volume of the atria is increasing, pressure will start decreasing by Boyle's law. So as the pressure starts decreasing, I will get a graph going downwards. So this graph we will call it as X descent. This is called as X descent. Now what is the reason for X descent? It is due to atrial relaxation. Atrial relaxation. Okay. But during this period, as atria is going into diastole, the ventricle will be going into systole. So ventricle starts contracting. We would have closed this valve, tricuspid valve, during the S1. Now the atria is relaxing, expanding. Ventricle is contracting to eject the blood to the pulmonary artery. So as ventricle starts contracting, the pressure will also be exerted on the tricuspid valve, which pushes the tricuspid valve into the right atrium, making the right atrial volume slightly reduce. So ये जो X descent है perfectly ऐसे नहीं दिखेगा, because midway the bulge of the tricuspid valve into the right atrium makes the right atrial volume decrease. By Boyle's law, volume decrease means pressure increased. So graph starts going up. So actual graph kaise dikhega? It will be like this and then starts going up. This small up is what we will call as the C wave. We will call it as C wave. And this C wave is because of the tricuspid bulge. It is due to tricuspid bulge into right atrium. And this corresponds to a phase of systole, क्योंकि इस time ventricle systole पे है, and that phase of systole is called as isovolumetric contraction. Isovolumetric contraction. Okay, but then this valve will not remain bulged into the right atrium throughout the ventricular systole, क्योंकि थोड़ी देर बाद ये pulmonic valve open होगा, blood starts moving into it, so the pressure exerted on the tricuspid valve will come down. तो ये जो inward bulge हुआ था, it will return back to its position, and thus we will catch up with the rest of the X descent. So X descent gets momentarily disturbed by the C wave, and that splits the X descent into X and X dash. X descent gets split into X and X dash by this tricuspid bulge, and that wave we call it as C wave. Okay, now atria is relaxed, the pressure has come to the bottom, right, close to the bottom. Atria is relaxed, so pressure in the atria is low, and because of the low pressure, it starts drawing the blood from superior and inferior vena cava. So now blood starts filling the atria. As the blood starts filling the atria, the pressure in the atria starts going up. So my graph will again take an upward turn now. This wave we will call it as V wave. We will call it as V wave. V wave refers to filling of the atria from the blood coming from superior and inferior vena cava. मतलब vein से आता हुआ blood से atria fill हो रहा है. So it is due to venous filling of the atria. Venous filling of atria. Why am I calling it as venous filling of atria? Because these are veins. Veins से blood atria में आ रहा है. क्यों आ रहा है? Because the pressure in the atria was low. Veins were full of blood. So fluid will move from high pressure to low pressure zone. V wave. So now atria has received the blood, pressure in the atria is high. Now this atria is ready to transfer this blood to ventricle, right? It is ready to transfer this blood to ventricle. Ventricle prior to this was doing ejection. Abhi ejection khatam hoga, pulmonic valve will close, and that will produce another sound now, and that sound will be S2. That sound will be S2. Now I will transfer the blood from atria to ventricle in ventricular diastole. पहले isovolumetric relaxation, उसके बाद में passive filling, और उसके बाद में active filling. So पहले जब passive filling start होता है तो blood starts moving from atria to ventricle. So atria is getting emptied, atrial pressure starts dropping down. So graph will now take the turn downwards. It will start going down, and this wave we will call it as Y descent. Y descent. Y descent is due to atrial emptying. Due to atrial emptying. In which phase of cardiac cycle? Atrial emptying during passive filling. During passive filling. So we'll have an active filling and a passive filling. Passive filling produces this Y descent. Passive filling के बाद active filling. So atria contract करेगा, pressure बढ़ेगा. That will be again a A wave. उसके बाद में फिर atria relax करेगा, giving rise to X descent in between a C wave, and then again I will have a V wave, Y descent. This continues. So now first level of MCQs from the JVP will be like these conditions. Means they will ask you A wave is due to, X descent is due to, C wave is due to, V wave is due to, and Y descent is due to. If you're not able to understand conceptually, you can still remember it better when you look at this point. What is it? There are easy ways to remember. A wave corresponds to atrial contraction and active filling phase of cardiac cycle. A, right? X descent corresponds to atrial relaxation. So when you read, give emphasis to the X letter, relaxation. Y descent corresponds to atrial emptying. So give emphasis to Y. Okay. V wave corresponds to venous filling. V for V, right? And C wave corresponds to the bulge of cusps of the tricuspid valve. So remember, it is the cusp bulge which is responsible for the C wave. Clear? Then they will ask you, where do you get which phase of cardiac cycle these waveforms can correlate with? Three things you have to remember: Y descent for passive filling, and C wave for isovolumetric contraction, and A wave for active filling. Okay, now let us look at some of the important abnormal waveforms of the JVP. Absent A wave. A wave is due to contraction of the atria. Where do I get absent A wave? When atria does not contract. When atria does not contract, atria does not contract in atrial fibrillation. So you get absent A waves in atrial fibrillation. Where do you get tall A waves? We get tall A waves when atria is forced to contract against a small tricuspid valve opening. So when atria is trying to contract and the opening is very small, the atrial pressure rises. So as atrial pressure rises, the A wave will become taller. So we can get that in tricuspid stenosis. In tricuspid stenosis, I can also get tall A waves if I have very small right ventricle, because small right ventricle will resist filling of the blood into it. And small right ventricle typically happens when I have pulmonary hypertension or pulmonic stenosis. So in tricuspid stenosis, right ventricular hypertrophy, pulmonary hypertension. Similarly, in cardiac tamponade and constrictive pericarditis, in these conditions, I can have tall A waves. We can have tall A waves. Okay. Then comes another term called as Cannon A waves. Cannon A waves refers to tall A waves only, but not all A waves are tall. Only few A waves appear tall. Remaining A waves appear normal. Like if all the A waves are tall, then we will simply call it as tall A waves. But if one A wave is tall, the remaining A waves are small, again one A wave is tall, intermittently tall A waves, then we call it as Cannon A waves. So Cannon A wave refers to intermittently tall A wave, intermittently tall A wave, which is seen in what conditions we see it? We see it in AV dissociation. AV dissociation means there is separation of atrial and ventricular rate. Normally atrial rate is equal to ventricular rate. पहले atrial contract करेगा, blood ventricle में पहुंचाएगा, फिर ventricle contract करके eject करेगा. Cycle goes on. So one time atrial contracts, one time ventricle contracts. But if atria contracts more than ventricle or ventricle contracts more than atria, we will call that condition as AV dissociation, atrioventricular dissociation, or divorce between atria and ventricle. They are no longer married. So that happens in various conditions. One condition where you will have atrial rate more than ventricular rate is when you have third degree AV block. When you have third degree AV block, which is also called as complete heart block, right? And another condition where you can have ventricular rate more than the atrial rate is when you have ventricular tachycardia or ventricular fibrillation. In these conditions, you can have AV dissociation, where you will get these Cannon A waves. Okay. Then this X descent. This X descent becomes steep or prominent. In all the conditions where A wave becomes tall, the X descent appears steep because ऊपर से बहुत height से नीचे की तरफ आ रहा है, so it appears steep. So prominent X descent is seen in all conditions with tall A waves. जहाँ पे भी A waves tall हैं, you will have prominent X descent. Okay. Then you have a prominent Y descent. Prominent Y descent, you have to remember only one condition for the exam, and that is the constrictive pericarditis. Constrictive pericarditis. This is one feature that helps you to differentiate between constrictive pericarditis and cardiac tamponade. Cardiac tamponade में, please remember, Y descent indicates passive filling. Cardiac tamponade में, there is so much of fluid in the pericardial space that it has literally compressed the ventricle. Passive filling is not possible. Ventricle is in a collapsed state. No passive filling means no Y descent. So in cardiac tamponade, Y descent will be absent. In constrictive pericarditis, you will have a prominent Y descent. Okay. Then you can have another condition where you can have a V wave which is tall, sometimes taller than A wave. A wave is the tallest wave. Sometimes V wave may be taller than the A wave. We will call it as prominent V wave. And sometimes the C wave will not be followed by X descent and V wave. It will be directly leading to V wave. So there is a fusion of the C with the V, fused CV wave. Both of them are seen in tricuspid regurgitation. Tricuspid regurgitation. And this fused CV wave is called as Lancisi's sign. It is called as Lancisi's sign, which is itself an MCQ. Okay. And then one last point you have to remember is absent Y descent. Where do you get absent Y descent? The absent Y descent is seen in cardiac tamponade. It is seen in cardiac tamponade. So I want you to literally by heart all these conditions, because JVP is one so important topic that almost every FMGE, every NEET PG exam there is a question. So if you at least remember the waveforms, the reasons behind that, and the important abnormal waveforms, and in which conditions you get, kind of 1 marks is assured for you, which for many students who get stuck at 149, it's a big deal, right? Okay, so after the JVP, let's go to the next chapter, which is about valvular heart diseases. A lot of MCQs come on valvular heart diseases, where most of the FMG students struggle to identify कि ये AS की बात हो रही है, MS की है, या this question is talking about TS or TR. So when you don't even recognize what disease or which valvular condition the question or story is talking about, you may not be able to answer the rest of the condition, right? So just to make it easier, I will give you a question. We will learn how to apply the concepts for the diagnosis of valvular heart diseases in a clinically oriented MCQ. So we have a question where a patient has presented with symptoms of raised JVP, ascites, and edema. Okay, these are his clinical features. On auscultation, there was a murmur. There was a murmur, which was a systolic murmur. It was a systolic murmur. It is heard in, there is an area where it is heard in left lower parasternal region. Left lower parasternal region. What is the diagnosis? Let me list few options as well. Okay, so option A is tricuspid stenosis, option B pulmonic stenosis, option C aortic stenosis, and option D tricuspid regurgitation. Okay, let me add one more option. It is mitral regurgitation. Okay, so how will I approach this question? So we can have a very simple logical approach to these kind of questions. What you have to do is, whenever you're reading a valvular heart disease question, there is 3 levels of information. एक symptoms का information है, दूसरा murmur का information है, and तीसरा कौन से area में murmur is best heard, in which area the murmur is best heard. So if you have these 3 levels of information, you will always be able to make the diagnosis. Okay, so वो कैसे है? So first look at the symptoms. So when you approach the symptoms, you have to decide whether the symptoms are suggestive of right side of the heart or the left side of the heart. So whenever I have problem on the left side of the heart, see, please remember how the circulation goes. This is my heart, right? So blood comes from the veins to the right atrium, then goes to the right ventricle. From the right ventricle, it goes to lungs, and after the oxygenation it comes to left atrium, from the left atrium to left ventricle, from there to aorta. So whenever I have problem on the left side of the heart, the pressure buildup leads to congestion of the lungs, and when lungs are congested, what is the main symptom that patient comes with? Dyspnea, shortness of breath, orthopnea, PND. When I have problem on the right side of the heart, the pressure buildup results in increase in the right atrial pressure, which shows up in superior vena cava pressure going up, inferior vena cava pressure going up. So superior vena cava pressure going up will show up as raised JVP, and inferior vena cava pressure going up shows up as hepatomegaly, because there is congestion of blood in the liver, and we will also develop ascites and edema. So whenever you read the question, you have to decide whether it is right-sided problem or left-sided. So when I see here raised JVP, ascites, edema, it is suggestive of right heart problem. So it kind of rules out at least few left-sided pathologies. What are those? Aortic stenosis and mitral regurgitation. These are already ruled out. I have to think of right conditions: tricuspid stenosis, pulmonic stenosis, and tricuspid regurgitation, right? After that, next we will apply the concept of murmur. So please remember, in tricuspid stenosis we get a mid-diastolic murmur. In pulmonic stenosis we get a ejection systolic murmur, and in case of tricuspid regurgitation also we get pansystolic. So these two are systolic. Tricuspid stenosis is also now ruled out. So I have to decide between these two, pulmonic stenosis and tricuspid regurgitation. So if I have the idea about the area, then this differentiation also becomes easier. So let us look at how do we approach. Okay, so to be able to deal with this, I need to have a fair idea about the areas of auscultation. Okay, so what are the major areas of auscultation? Because every valve, the murmur is best heard in one particular area. So let us say this is sternum. Okay, so on the left second intercostal space, this is right, this is left. So on the left second intercostal space, we have an area. Left second intercostal space is the pulmonic area. So the murmur of pulmonic valve, whether it is pulmonic stenosis or regurgitation, will be best heard in the left second intercostal space. And on the right side, we have the aortic area. So right second intercostal space is aortic area. So the murmur of the aortic stenosis is going to be better heard on the right second intercostal space. Okay. Then left lower parasternal region. This is left lower parasternal region. This is the area for the tricuspid valve. This is the area for tricuspid valve. Tricuspid valve. And wherever you have the apex of the heart, apical beat, where you feel, that area will be called as, wherever you have the apex, that area will be called as the mitral area. That will be called as mitral area. Okay, so now if I have a fair idea about this area, I already know from which valve the murmur is coming. So already my differential diagnosis becomes so narrowed down. Now look at this question. Which area the murmur is coming from? Left lower parasternal region. So which is the area for the tricuspid valve, right? It's a tricuspid area. So if I have a pathology in the tricuspid valve, this is where the murmur will be heard. So if I get a question like this, answer is so straightforward, right? This murmur is coming from tricuspid valve only. So it has to be either TS or TR. It can't be AS, MR or PS. Those are already ruled out. So between TS and TR, I have to decide whether I should go ahead with TS or TR. So if I have an idea that it is systolic murmur which is seen in TR, that is also sorted. So what we will do is we'll make a list of valve conditions and murmurs. And it is very easy to remember because the murmur of two valves will be same. That is murmur of aortic valve pathologies, AS and PS will be same. Murmur of AR and PR will be same. Murmur of MS and TS will be same. Murmur of MR and TR will be same. So murmur of AS and PS will be what we call as ejection systolic murmur. It's an ejection systolic murmur. So if I have to put a graph of it, the murmur is going to sound somewhat like this. It is in the systole. So that means it is happening between S1 and S2. So in the systole, the first phase of cardiac cycle is isovolumetric contraction. Murmur will not be heard at that point of time. After isovolumetric contraction, the aortic valve or the pulmonic valve open, and when the blood tries to pass through that narrow valve, it will encounter the resistance and the murmur will be created. Okay, so the murmur starts after isovolumetric contraction when the blood starts moving. First phase is rapid ejection and then there is slow ejection. Murmur first starts here, increases in the intensity and eventually decreases, because in the rapid ejection more turbulence, slow ejection decreasing turbulence. So this kind of murmur we call it as ejection systolic murmur, क्योंकि ये ejection phase में चल रहा है, rapid and slow ejection में, right? What extra points you need to know about aortic stenosis? The most common cause for AS is age-related degeneration of the valve. But the most common cause for AS in young individuals who are not elderly, for them it is presence of bicuspid aortic valve. Bicuspid aortic valve. Normally there are three cusps, but some people are born with only two. They may develop aortic stenosis in young age. Otherwise, you may develop AS elderly when we cross 70, 80 years of age. Okay. Then murmur of AR and PR. The murmur of AR and PR are going to be early diastolic murmurs. They are going to be early diastolic murmurs. So diastole happens between S2 and S1. And when we say early diastolic, it is primarily running in the isovolumetric relaxation phase. There is an isovolumetric relaxation, passive filling and active filling inside the diastole. So this murmur starts in the isovolumetric relaxation and ends there. It doesn't go into passive filling and active filling. So we are going to call it as early diastolic murmur. Clear? Okay. So in the AR, I want you to remember the named signs, or what you call as peripheral signs of AR. Peripheral signs of AR. Okay, I'm not going to list them here because it will consume more than 20 minutes, but it is available to you in the notes. You can please go through and try to remember all the named signs of AR. Okay. Then coming to the mitral stenosis and tricuspid stenosis, the murmur of mitral stenosis and tricuspid stenosis is going to be mid-diastolic murmur. Mid-diastolic murmur. Mid-diastolic murmur. So that means, again, this is running in the diastole. So between S2 and S1, it is going to happen, but it is not running in the isovolumetric relaxation phase. It starts after the isovolumetric relaxation phase, that is passive and active filling. So it starts in the passive filling, and then the intensity of the murmur increases in the active filling. So we call it as mid-diastolic murmur with pre-systolic accentuation. The most common cause for MS is rheumatic heart disease. Rheumatic heart disease is the most common cause for mitral stenosis. Okay. The murmur of MR and TR are going to be pan-systolic. They are going to be pan-systolic. Pan means throughout the systole. Systole happens between S1 and S2. This murmur runs throughout the systole. Means it starts with the S1, goes on all the way till S2. Goes on all the way till S2. Clear? So these are the important murmur conditions that you need to remember. So if you by heart this table, that's first level information. If you're aware of the areas of auscultation and from the symptoms you can differentiate between right side versus left side, you will always be able to reach the diagnosis of these clinically oriented MCQs. Like now let us apply that. So when I look at the symptoms, these symptoms are suggestive of right side of the heart. That means it can't be aortic stenosis, it can't be mitral regurgitation. Those options are ruled out, right? Now looking at the area of auscultation, that is left lower parasternal region, which is tricuspid area. So pulmonic stenosis is also ruled out. How to differentiate between TS and TR now? So if I have this table, I know that TS is mid-diastolic and TR is pan-systolic. So what this question is talking about? Systolic. If it is TS, it should be diastolic. So this is also now ruled out. This is also ruled out and the diagnosis becomes TR. This is how you can make the diagnosis of valvular heart diseases. If you are aware of these additional MCQ points, it becomes even more easier to address the questions which are clinically oriented. Clear? So for the valvular heart disease, please follow this approach. First, look at the symptoms, auscultation, murmur, what is it, and which area the murmur is best heard. Try to apply the information that we have, the area of auscultation and the murmur table. If you have a conceptual understanding, good. If not, just memorize this. It's more than enough. Okay. So after the valvular heart diseases, let's get into also some abnormal heart sounds. Abnormal heart sounds. Okay. So what are the abnormal heart sounds you need to remember? So you're already familiar with what causes S1. You know what causes S2. What causes S2. Okay. And then you should also be aware of some abnormal sounds like clicks and opening snaps. So what causes S1? S1 is due to closure of mitral valve and tricuspid valve. It is mitral and tricuspid closure produces S1, and closure of aortic valve and pulmonic valve produces S2. So with respect to S1, they will mainly ask you where do you get loud S1 and where do you get soft S1. So please remember, loud S1 you get mainly in mitral stenosis. Mitral stenosis, and any condition where there is short PR interval, and you get soft S1 in opposite of mitral stenosis, that is mitral regurgitation, and opposite of the short PR interval, which is prolonged PR interval. Okay. Now closure of aortic valve and pulmonic valve produces S2. From the S2, they will not ask you which produces loud S2, where you get soft S2. They will mainly ask the splitting of S2. S2 is comprising of aortic closure called A2 and pulmonic closure called P2. Normally there is a gap between the two. This gap increases in inspiration, decreases in expiration. That is physiological split. So they will ask you two important MCQs here. One, where do you get the so-called paradoxical splitting of the S2? Paradoxical splitting. Normal splitting is more in the inspiration. Agar ulta ho jaye, the split becomes more clear. The separation between A2 P2 becomes more clear in expiration. We call it as paradoxical split. And दूसरा एक fixed split. Fixed wide split, or wide and fixed split. These are the two important MCQ points I want you to remember. Paradoxical split you get in severe aortic stenosis, and you can also get it in left bundle branch block. And this wide and fixed split, it's a very, very important MCQ point. You get that in atrial septal defect. Okay, definitely there are mechanisms behind this, but in this class I'm not getting into the mechanisms or concepts because we don't have the time. It's for the quick revision. If you've already read, it will become much more easier. Okay, so we have learned a little bit about the JVP waveform, the pulse waveform, some important MCQ focused abnormal waveforms of the pulse, MCQ focused abnormal waveforms of the JVP. Okay, and then how to approach the valvular heart diseases and important abnormalities of S1 and S2. Apart from that, we have two more abnormal sounds. One is S3, S4. Okay, so what is this S3? Normally only closure of the valves produce sound, opening normally does not produce sound, and movement of blood from atria to ventricle or ventricle to arteries, aorta, pulmonary artery, does not produce sound. But if it produces sound, we will call it as S3 or S4. So S3 is because of the, like let us say this is my left side of the heart that I'm looking at. This is left ventricle. So I fill the blood from the left atria to the left ventricle during ventricular diastole. So pehle I will do a passive filling, baad mein active filling. So as I start doing the passive filling, the blood moves from atria to ventricle. It will come and hit the wall of the ventricle, does not produce a sound. But if the ventricle becomes dilated, it will produce a sound. So S3 is the sound produced by passive filling. Important point to remember here is that whenever you think of S3 or think of passive filling into. Second point you have to remember is that normal ventricle, if I do passive filling, no sound produced. But if I have a large ventricle, then sound will be produced into large compliant left ventricle. So to produce S3 मुझे क्या चाहिए? I need a left ventricle which is dilated. It has become large. Okay. And after this passive filling, I will have an active filling where atria actively contracts and pushes the blood into the ventricle. That also does not produce a sound. But if I make this ventricle develop concentric hypertrophy and become small, forcefully pushing the blood into a small ventricle can produce sound. That we are going to call it as S4. So S4 is sound produced by active filling into small non-compliant LV. So 2 points we have to remember here. कौन सा phase of diastole की बात हो रही है to produce the sound, and what should be the status of the ventricle. So for S4 I need active filling and I need small non-compliant left ventricle. Okay, so question wise they will ask you in what all conditions you see it. So this S3 can be physiological. Where it is physiological, S3 can be physiological in pregnancy and children, also athletes, or it can be pathological as well. Pathological in patients with dilated cardiomyopathy and systolic heart failure. Dilated cardiomyopathy and systolic heart failure. S3, yes, Chandan Patra, yes, that's what we are talking about. Okay, so when S3 comes, we will have a gallop rhythm. If you are familiar with Beethoven's symphony, it resembles third symphony. It is like S1, then S2, diastole starts. So S1, S2, S2 के बाद diastole है. Soon after the S2, you will have the S3 coming up. So it sounds like dum tada. Tada is S2 followed by the S3. Dum tada, dum tada. That is how the Beethoven's third symphony also sounds like. The background music goes like dum tada, dum tada. So you can call it as gallop rhythm. Okay. S4 is always pathological. S3 can be physiological, but S4 is always pathological. It is not physiological. And it can be seen in what all conditions? It is mainly seen in patients with concentric LVH. Whatever causes concentric LVH, hypertension, aortic stenosis, and all those conditions, you can have it. Okay. Then we have so-called clicks. Normally, opening of the valves does not produce a sound, but if the valve is stenosed while opening, it may produce a sound. So which valve opening produces a click? Mainly aortic and pulmonic valve opening. So we will call that condition as aortic stenosis and pulmonic stenosis. What is this click? It is the sound produced by opening of stenosed aortic valve or pulmonic valve. Similarly, you have an opening snap, which is nothing but the sound produced by opening of mitral or tricuspid valve when they are stenosed. So we'll get that in mitral stenosis and tricuspid stenosis. So this is the sound produced by opening of stenosed mitral valve or tricuspid valve. Okay, so that is about the abnormal heart sounds. So what points you need to remember? With respect to S1, I mainly want you to remember where do you get loud S1 and its relationship with the PR interval and mitral stenosis. So it is seen in mitral stenosis and in patients with short PR interval. Okay, and they will ask you where do you get this paradoxical splitting of the second heart sound and where do you get this wide and fixed split of the second heart sound. Not only they will ask you where do you get this wide split second heart sound, sometimes they will give it as a clue for the diagnosis of ASD. So this is a very, very important point I want you to remember. Whenever a question talks about wide fixed split of S2, it is talking about atrial septal defect. Okay. S3, S4, please don't get confused. S3 is passive filling, large LV. S4 is active filling, small LV. S3 can be physiological or pathological. S4 is always pathological. Okay. So now let's go to the next topic in cardiology, which is heart failure. So what is heart failure? Heart has two work. Mainly when we say heart, we have to think of ventricle. Atria तो ज़्यादा कुछ काम नहीं करेगा, थोड़ा बहुत active filling करता है. Otherwise, most of the blood transfer from atria to ventricle happens passively. So when we think of heart, it is ventricle. Ventricle has two work. One, relax to receive the blood from atria. Contract to eject the blood. Contraction happens in systole, relaxation happens in diastole. So if one of them is impaired, we will call it as heart failure. So heart failure, we will define it as impaired ventricular ejection or relaxation. So if there is impaired ventricular ejection, that is systolic heart failure. Systole के टाइम पे जितना force generate करना चाहिए ventricle उतना नहीं कर पा रहा है. And if it is not able to relax during the diastole, it will not be able to receive the blood from the atria. So then we will call it as diastolic heart failure. Diastolic heart failure. Now, how will I diagnose a patient as having heart failure? The diagnosis is not purely clinical because similar symptoms appear in multiple conditions. So you should have signs and symptoms of heart failure, signs and symptoms of heart failure. But in addition to that, you need to prove that the signs and symptoms of heart failure are because of heart failure. So, and the proof comes from raised N-terminal pro-BNP levels. Pro-BNP levels. So, if they ask you what is the investigation of choice for diagnosis of heart failure, investigation of choice for heart failure, the answer is going to be N-terminal pro-BNP levels. Chandan Patra, very good. Okay, so once I have established the diagnosis that this is a case of heart failure, I have to make the management steps. And for us to do the management, we need to know which type of heart failure it is, whether it is systolic heart failure or diastolic heart failure. And that assessment is based on the ejection fraction. So what is ejection fraction? We all know ejection fraction is nothing but stroke volume divided by end diastolic volume multiplied by 100. Ejection fraction is a determinant of how much force the ventricle is able to generate during the systolic contraction. अगर ये ठीक से systole में contract नहीं कर पाएगा तो ejection fraction कम होगा, right? So normal ejection fraction is between, normal EF is between 60 to 70%. 60 to 70%. Okay, so whenever we have low ejection fraction, that means systolic heart failure है, and ejection fraction ठीक है फिर भी heart failure है तो diastolic heart failure है. So based on that, heart failure can be classified as low ejection fraction or reduced ejection fraction and preserved ejection fraction. Heart failure with reduced EF, heart failure with preserved EF, and heart failure with mid-range, neither sufficient enough to call it as preserved nor sufficient enough to call it as reduced. So when EF is less than 40%, we will call it as reduced ejection fraction, and when EF is more than or equal to 50%, we will call it as preserved ejection fraction, and if it is between 40 to 49, we will call it as mid-range ejection fraction. Okay, so this heart failure with reduced ejection fraction is nothing but systolic heart failure. This is systolic heart failure, and preserved ejection fraction is diastolic heart failure. So two MCQs are possible here. They will ask you what is the most common cause for systolic heart failure or heart failure with reduced ejection fraction, and what is the most common cause for heart failure with preserved ejection fraction. So the most common cause for heart failure with reduced ejection fraction is going to be ischemic heart disease. You have an ischemic heart disease, some part of your myocardium is dead, it cannot contract properly, so it will not be able to generate sufficient force, so we'll have low EF. If I have hypertension, I will develop concentric LVH, ventricle becomes muscular but fails to relax well, so we'll have diastolic heart failure. So the most common cause for diastolic heart failure is hypertension. Hypertension is the most common cause for diastolic heart failure or heart failure with preserved ejection fraction. Okay, now when I have a patient with heart failure, how do I manage it? Unfortunately, we lack the knowledge and experience for the effective management of heart failure with preserved ejection fraction, but we have a lot of experience treating patients with heart failure with reduced ejection fraction. So what we follow now is the management protocol for heart failure with reduced ejection fraction with confidence. Same thing we generally extrapolate for the preserved ejection fraction. So what management focuses on? Management focuses on few key drugs. What are the drugs which will have long-term impact in reducing the mortality? So the first class of drugs that reduces the risk of death in a patient with heart failure is going to be AC inhibitors or ARBs. The second class of drugs that reduce the risk of death in patients with heart failure is going to be beta blockers, preferably cardioselective beta blockers. Then third class of drugs, dilated cardiomyopathy, yes, that is also systolic heart failure. Dilated cardiomyopathy, basically yes, left ventricle is dilated, the muscle is thinned out, it doesn't produce a sufficient force of contraction. Okay, yes, the third class of drugs, which is relatively new, called as ARNI, angiotensin receptor neprilysin inhibitor. Pharmacs would have given a long list of newly developed drugs and drugs in clinical research stage, But one that is practically available in India is mainly a combination of sacubitril, which is an neprilysin inhibitor, plus valsartan. Sacubitril plus valsartan, which is a ARB. So ARNI refers to angiotensin receptor as well as neprilysin inhibitor. So sacubitril is neprilysin inhibitor and valsartan, as you know, is an ARB. Okay, so fourth class of drugs that reduce the risk of death in patients with heart failure is going to be SGLT2 inhibitors. SGLT2 inhibitors. Okay, and the fifth one, spironolactone or mineralocorticoid receptor blockers. Mineralocorticoid receptor blockers. So all these drugs are known to decrease mortality or death risk in patients with heart failure with reduced ejection fraction. Okay, then you have to remember one extra point. Digoxin and other inotropic agents, though used in the past for the symptomatic benefit because they stimulate the heart to contract more and improve the ejection fraction, but they increase the risk of death. So digoxin is no longer preferred in the management of chronic heart failure. They are associated with increased mortality. This is a repeatedly asked MCQ. Which of the following drug is associated with increased risk of death or mortality in patients with heart failure, or which of the following is not associated with mortality reduction? All these drugs reduce the mortality. This increases the mortality. Good. Okay. So next, from the heart failure, we will go to another important topic, that is constrictive pericarditis. And mostly in the MCQs, they're going to ask you to differentiate it from cardiac tamponade. Okay. So what is this constrictive pericarditis? Constrictive pericarditis is a condition where you have stiffening. Let us say this is the heart. This heart has a right ventricle and a left ventricle. And around this, we have one layer of pericardium which is adherent to the myocardium, which we call it as the parietal pericardium. And then we have one adherent to myocardium called visceral, and one separated from it called as parietal. Constrictive pericarditis is a condition where these two layers of the pericardium become fibrosed, become stiffened, and they adhere to the myocardium. So constrictive pericarditis, there is stiffening or fibrosis of pericardium, and this results in reduced expansibility. So the amount of stretch that pericardium can go through is decreased. Reduced expansibility. And because of the reduced expansibility, so when do the heart expand? Heart expands during diastole. जब ventricle में blood भरता है तो वो expand करता है. Systole में ventricles contract, so heart becomes smaller. Diastole में ventricles fill, so it becomes wider. So when I'm not able to expand the pericardium, which phase of cardiac cycle I'm disturbing? Not the systole. I am not allowing the ventricle to fill properly during diastole. So that results in reduced ventricular filling during diastole. Ventricular filling during diastole. Okay. If you have to remember precisely which part of ventricular filling is mainly impaired here, it is going to be reduced duration of passive filling. Reduced duration of passive filling. So now I have to do more of transfer of blood from atria to ventricle during active filling, and unfortunately this affects right ventricle more than left ventricle. So primarily you have to think of right heart disease when you think of the constrictive pericarditis. So when I have to fill the blood from right atrium to right ventricle, the passive filling will not run for the full normal time, because as I start filling, the ventricle starts expanding, but it can only expand till the pericardium limit of expansibility reached. Here the limit of expansibility is reduced. So beyond that I cannot do the passive filling. Forcefully I can fill during the active filling. So there is reduced duration of passive filling. What is the most common cause for this constrictive pericarditis? The most common cause, you have to remember two. Worldwide and in India. So worldwide, the most common cause is recurrent acute pericarditis. It is recurrent acute pericarditis. बार बार pericarditis होगा, हर बार pericardium becomes fibrosed, eventually it will become stiff. But in India, it is the tuberculosis. Tubercular pericarditis is the most common cause for constrictive pericarditis. Okay. So what clinical features these patients of constrictive pericarditis will present? I am struggling to fill the blood from right atrium to right ventricle. So right atrial pressure will increase. That will result in increased right atrial pressure will lead to raised JVP. Okay. So with the raised JVP, right ventricular filling reduced means less amount of blood comes to right ventricle, less amount of blood goes to lungs, less amount of blood comes to the left ventricle. So I may also develop hypotension, which you can also get in other conditions. Hypotension. Okay. Third, importantly, when we look at the JVP, we have to also talk about the waveforms. So I can have a tall A wave. Why? Because burden is more on the active filling. Passive filling is of reduced duration. So ज़्यादा filling active में हो रहा है. So tall A wave. And because A wave becomes tall, by default that results in, I've already told you, whenever A wave becomes tall, we will have a prominent or steep X descent. Prominent X descent or steep X descent. यहाँ पे passive filling हो रहा है. Passive filling is there. It's not totally absent. Passive filling is there, but the duration is reduced. So that results in, again, a prominent Y descent as well. Prominent Y descent as well. Okay, clear? Now for the diagnosis, what is the investigation of choice? Investigation of choice is right heart catheterization. Right heart catheterization. I have to put a catheter into the right side of the heart and prove that there is reduced duration of the passive filling. So right heart catheterization, I can prove that with a sign which is called as square root sign. It is called as square root sign. It's called as square root sign. For now, just remember what is it. In the main videos, I have explained the mechanism behind that, but of course, now no need to waste time behind that. Just remember that whenever you think of square root sign in a patient with right heart pathology, think of constrictive pericarditis in the exam. Okay. There will be one more clue in clinical features, and that is a sound, abnormal auscultation sound called as pericardial knock. Pericardial knock on auscultation. Now, what is this pericardial knock? So when I auscultate these patients, I hear a sound in the diastole. Why am I getting the sound? Because as the blood starts filling the ventricle starts expanding. Okay. But this expansion does not continue for full diastole or full passive filling. It keeps expanding, but once pericardium's limit of expansibility is reached, it cannot expand anymore. So it suddenly stops. And then because it was expanding, it was in a state of inertia. Inertia means like when you're driving, you might have experienced that you're constantly moving. Suddenly you apply the brake, you lean forward because your body was in inertia of momentum. वैसे ही the ventricle was in the inertia of momentum. When we suddenly stop it, just like how our body vibrates on braking, the ventricle also vibrates. That produces a sound. That sound is what we call as pericardial knock, which is a diastolic sound because ventricle is expanding in diastole. Okay. So key points to remember about the constrictive pericarditis is that here you get prominent Y descent on JVP and you get this pericardial knock on auscultation and you get this square root sign, which is also called, okay, I forgot to mention that, it is also called as dip and plateau sign. Dip and plateau sign on right heart catheterization. Okay. Now same features you can get in the cardiac tamponade also, because what happens in cardiac tamponade? In cardiac tamponade, you have massive pericardial effusion. Massive pericardial effusion. And this too much of fluid in the pericardium compresses the ventricles and make them collapse. So let us say that this is the heart that I'm looking at. This is my right ventricle. This is my left ventricle. And in the pericardial space, the fluid starts accumulating. And this accumulation of the fluid will start exerting pressure on the ventricles. And which ventricle is most likely to collapse first? Right ventricle is not very muscular, so that is the one which collapses first. So under the influence of this pressure, the right ventricle collapses. The right ventricle collapses. So the first ventricle to get collapsed in patients with cardiac tamponade is the right ventricle. So in the tamponade, an important finding is that you should know there is collapsed RV. This is nothing but pericardial effusion. So the difference between the pericardial effusion and cardiac tamponade is that effusion is so high that it caused the collapse of the right ventricle. Then we are going to call it as cardiac tamponade. So this massive pericardial effusion results in collapsed RV. Then it is cardiac tamponade. And this collapsed RV results in collapsed RV cannot open up. So we cannot do passive filling. So we'll end up with absent passive filling. जो भी blood right ventricle में आएगा, it will mostly come during active filling. Forcefully इस collapsed ventricle में थोड़ा बहुत हम push कर पा रहे हैं. So there is absent passive filling. And this is the main difference between the cardiac tamponade and constrictive pericarditis. Constrictive pericarditis also is affecting filling, and the tamponade is also affecting filling, but in constrictive pericarditis, passive filling happens at least for some part of time. Here, absolutely absent. So you have absent passive filling. So in terms of clinical features, these patients will also present with, okay, again, I forgot to mention the causes. The most common cause for cardiac tamponade is hemopericardium, collection of blood in the pericardial space. And hemopericardium most commonly happens because of, the most common cause for hemopericardium is trauma. Trauma can be road traffic accident as well as iatrogenic. When we do thoracic surgery and all, we can cause cardiac tamponade. Okay, so in terms of clinical features, these patients will also present with raised JVP. Then because of the filling of the right ventricle is reduced, the amount of blood going to lungs is reduced, amount of blood coming to the left side of the heart is reduced, so amount of the stroke volume left side can generate is reduced, so we can have hypotension here as well. But in auscultation of the constrictive pericarditis, we had pericardial knock. So here we'll not have that knock. Instead, fluid is not a good conductor of sound. So all the sounds generated by closure of the valves will become muffled. So we can have muffled heart sounds. Muffled heart sounds. Now when you look at the JVP waveforms, passive filling is totally absent. Whatever filling that is happening is in active filling. So I will have a prominent A wave because of the major active filling happening. And as I've already told you, when you have prominent or tall A wave, you will have prominent X descent as well. Prominent X descent. But because there is no passive filling and the wave of passive filling is Y descent, there is no passive filling, so we'll have absent Y descent. Absent Y descent. And this is a differentiating feature between the tamponade and constrictive pericarditis. In constrictive pericarditis, we had prominent Y descent. Here we have absent Y descent. And collectively, the JVP changes, hypotension and muffled heart sound together is called as Beck's triad. It's called as Beck's triad. Okay. And when you do investigations in a patient with the cardiac tamponade, you can see on the ECG. On the ECG, you can get two findings. The fluid here filters out the voltages from the heart reaching to the electrodes. So we will have low voltage complexes. We'll have low QRS voltage. Second thing we can get in more severe pericardial effusions is that the heart keeps moving inside the pericardial fluid to and fro. And this movement makes the QRS complexes go alternatively tall and small. So we'll call that as electrical alternance. We call it as electrical alternance. Electrical alternance refers to alternating high and low QRS voltages. Alternating high and low QRS voltages. So here one QRS will be tall, the next will be small. The next QRS will be tall, the next will be small. This is what we call as electrical alternance. Okay. I put a small table for us to compare between cardiac tamponade and constrictive pericarditis because this is where the examiners are going in last 3-4 years. The questions are centered around this. So in both cases, anyway, JVP will be raised, but in case of the cardiac tamponade, the Y descent is absent. And in case of constrictive pericarditis, Y descent is present. In fact, it is prominent. And this prominent Y descent is also called as Frederick's sign. Frederick's sign. Okay. Then you can get the Pulsus paradoxus in cardiac tamponade. In constrictive pericarditis, it is usually absent. Need not always, but it is usually absent. Okay. Then in cardiac tamponade, you are not generally expecting to see Kussmaul's sign, but you get to see that in constrictive pericarditis. Okay. Apart from that, when you do a chest X-ray, in cardiac tamponade, you get, like on the X-ray in cardiac tamponade, you get this particular water bag shaped heart. It's called as water bag or money bag heart. Money bag heart. On the other hand, in the constrictive pericarditis, especially when there is recurrent acute pericarditis as the cause, you will get a pericardial calcification, because when you have recurrent inflammation, there is scarring, fibrosis, and healing with calcification. So you can see calcified pericardium. Okay. Key point, that is what examiners have been asking repeatedly, is the absent Y descent and present Y descent in tamponade versus constrictive pericarditis. Okay, clear? So the next chapter that we're going to talk about is acute rheumatic fever. Acute rheumatic fever. So what is this acute rheumatic fever and how is it different from rheumatic heart disease? Acute rheumatic fever basically is an autoimmune acute condition of the heart. But this autoimmunity is triggered by infection. This is not an infectious disease. It's similar to GB syndrome. In GB syndrome, an infection triggers your immune system to produce antibodies. Antibodies cause nerve damage. Here, an infection which is mainly group A beta hemolytic streptococci through throat infection or skin infection triggers your immune system. Immune system produces antibodies and inflammatory cytokines. They cause damage to various tissues, mainly heart. Right? So what is it? It is an infection triggered. It's an infection triggered autoimmune disorder affecting multiple systems. Affecting multiple systems. It's a multi-system autoimmune disorder. It is not a single system disease. The most common infection responsible, of course, it is the group A beta hemolytic streptococci. Group A beta hemolytic streptococci. And within that, it is mostly throat infection which is more commonly responsible than the skin infections. Skin infections are extremely rare to cause rheumatic fever, mostly throat infections. Skin infections are commonly involved when you think of post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. There also throat infection is much more common. Okay, so usually what happens is you will have group A streptococcal pharyngitis, and 3 to 4 weeks later, patients develop acute rheumatic fever. Acute rheumatic fever. So during this period, body produces antibodies trying to kill these beta hemolytic streptococci, but those antibodies cause damage to our own tissues. That's how I end up with acute rheumatic fever. Okay, so when I said multiple systems, they will also ask you what is the most commonly affected system. Most commonly affected system is musculoskeletal system, and the most common manifestation is going to be polyarthritis. Polyarthritis is the most common manifestation. So when someone presents with polyarthritis 3 to 4 weeks after developing a group A beta hemolytic streptococcal throat infection, I should suspect the possibility of rheumatic fever and have to apply the criteria for diagnosis. Okay, so can anybody tell me what is the name of the criteria that is used for the diagnosis of rheumatic fever? So I will tell you two criteria. One is called as revised zones criteria. The other one is called as Duke criteria. So which one do we apply for the rheumatic fever? Which one is for rheumatic fever? One is for infective endocarditis, one is for rheumatic fever. So many students get confused in the examination hall between these two and the two conditions. Even now many students have no clarity between rheumatic fever and infective endocarditis. Infective endocarditis is a pure infectious disease where infection affects the endocardium and the valves. Here it is not an infectious disease. Infection triggers immune system to cause damage to the systems. Okay, so this revised Jones criteria is for the acute rheumatic fever or rheumatic fever, and Duke's criteria is for the infective endocarditis. So if you have a tendency to get confused, just remember one thing. Remember RJ, radio jockey, right? So for rheumatic fever, we have Jones criteria. And remember identity card, ID. For infective endocarditis, we have Duke's criteria. Infective endocarditis, Duke's criteria, ID card. RJ, radio jockey, right? That is for rheumatic fever, we have Jones criteria. Okay. Now the current revision of the Jones criteria focuses on classifying the population into low risk, moderate and high risk. Now India falls under high risk. It is endemic to us, right? So we are following revised Jones criteria, and for India what we follow is, because India is a high risk population, so we'll apply the revised Jones criteria for high risk population whenever we get question in the exam. Okay, so according to this there are major criterias and minor criterias. So what are the major criterias? There's an easy way to remember the major criterias. You can remember it with the mnemonic cases, right? So where C stands for carditis. Carditis means inflammation of the heart. It could be like in rheumatic fever, we say it causes pancarditis, means it can cause endocarditis, it can cause myocarditis, it can cause pericarditis as well as valvulitis. So carditis. A stands for arthritis. Arthritis. Here arthritis primarily refers to polyarthritis, and in the high risk population even monoarthritis and polyarthralgia, all of them are considered as criteria satisfying arthritis. So that means we are talking about polyarthritis, monoarthritis, and not that, even polyarthralgia means there is no evidence of inflammation of the joint, only pain. We will take it as major criteria for high risk population, polyarthralgia. Okay, then S here stands for Sydenham's chorea. Sydenham's chorea. E here stands for a skin lesion called as erythema marginatum. Erythema marginatum. And another S stands for another skin lesion called as subcutaneous nodules. Subcutaneous nodules. So these are the major criteria. Okay. So what are the minor criteria? So minor criteria include fever, raised ESR or CRP, third, prolonged PR interval. Prolonged PR interval. The last point is important. The last point is monoarthralgia. Monoarthralgia means pain in single joint, pain in multiple joints, inflammation of multiple joints, inflammation of even single joint. All of them are considered as major criteria, and this one is minor criteria. And this is where they tend to introduce confusion. So that's why I want you to primarily remember that for high risk population like India, even pain of multiple joints is a major criteria. Without the evidence of inflammation, there is no redness, no swelling, patient is complaining of pain of multiple joints, major criteria. There is swelling, visible redness of single joint, major criteria. Multiple joints, so more than happy to call it as major criteria. But even if one joint is aching, we will count it as minor criteria, right? So these are the minor criteria. Okay, now for the diagnosis, I either need two major criteria or one major plus two minor criteria. Two minor criteria are required for the diagnosis of acute rheumatic fever. So once I have diagnosed acute rheumatic fever, we should know that there is probably involvement of heart, multiple joints, and every time heart gets affected, inflammation results in healing with scarring. So valves will heal with scar and eventually will lead to stenosis of the valves. and that stenosis of the valves is what we call as rheumatic heart disease. So recurrent acute rheumatic fever leads to valve stenosis, then we call it as rheumatic heart disease. Acute rheumatic fever is just one episode, बार बार होगा, हर बार हार्ट को थोड़ा बहुत डैमेज करता जाएगा, eventually heart becomes, valves become stenosed, then it is rheumatic heart disease. So as a doctor, it's my job to make sure that current problem is solved and then recurrence is prevented, right? So for the management, we need to give antibiotics. They will ask you what is the antibiotic of choice, and then we will use NSAIDs primarily to treat the joint pains, and then for chorea, what I can use. So antibiotic, the drug of choice is going to be benzathine penicillin G. NSAIDs we can use. For chorea, we can use valproate or carbamazepine. Valproate or carbamazepine. Valproate or carbamazepine. Okay, so that's a quick take on the acute rheumatic fever. Whenever there are criteria involved, examiners tend to ask questions based on that. So I want you to memorize this revised zones criteria for high risk population. In your notes and books, you will also have the criteria for low risk population. Of course, it can lead to more confusion if you try to read low risk population. When they are pitching for India, it's of course we are high risk population. So this is what I want you to remember mainly. Okay. So next, from here, we will go to the important topics from neurology. So in the cardiology, we have learned about the pulse, JVP, heart failure, constrictive pericarditis, cardiac tamponade, and rheumatic fever. Now in the neurology, we will primarily focus on 3-4 important diseases: myasthenia gravis, GB syndrome, current stroke management protocol. But before we go there, again, questions in neurology are going to become more and more clinically oriented. So you should recognize which particular disease this question is talking about. And one of the important key feature that helps us to differentiate between the different neurological conditions is whether patient is suffering from damage to upper motor neurons or lower motor neurons. So basically what happens is when brain has to communicate to a muscle for the contraction, the motor area of the brain sends a signal which will pass through the brain stem and then the spinal cord, and the signal has to reach the muscle. So the signal has to travel from the motor area of the brain. So one neuron brings it to the spinal cord. This neuron crosses at the lower end of the medulla and then enter the spinal cord. And once it enters the spinal cord, it descends as what we call as corticospinal tract. And from the spinal cord, the signal is picked up by another neuron which brings it to the neuromuscular junction. So I have two levels of neurons involved in controlling the movement. The one from brain to spinal cord, we will call it as upper motor neuron. Upper motor neuron is there from brain to spinal cord. And there is one from the spinal cord to the neuromuscular junction, we will call it as lower motor neuron. Damage anywhere from brain, brainstem, spinal cord, lower motor neuron, neuromuscular junction, muscle, everywhere will lead to weakness. But from here to here, damage results in weakness with some peculiar clinical manifestations. Damage here to here results in weakness with some peculiar clinical manifestations. So if I'm able to differentiate between UMN versus LMN, I already know where is the damage. If the features are suggestive of LMN damage, that means the damage is somewhere between spinal cord to the neuromuscular junction. If the features are suggestive of UMN, damage may be in the brainstem or the spinal cord, right? So that's why you should always remember UMN versus LMN. So when I have UMN lesion and when I have LMN lesion, three things that will help us to differentiate is: first one, tone; second one, reflexes; third one, atrophy and fasciculations. So we'll first talk about what happens. In all the cases, there will be weakness, damage to UMN as well as LMN, but we will talk about tone, deep tendon reflexes, and atrophy fasciculations. So weakness will be present whether UMN is damaged or LMN is damaged, but damage to UMN results in increased tone, and damage to LMN results in decreased tone. So increased tone, we will call here it as spasticity. It's called as spasticity. And decreased tone, we call it as flaccidity. Okay. Deep tendon reflexes will also be exaggerated in UMN lesion, they will be diminished or absent in LMN lesion. Okay, another thing is the plantar reflex, which I forgot to mention. The plantar reflex is a superficial reflex. The plantar reflex is extensor, which is also called as Babinski sign positive. Babinski positive, and it will be downgoing or flexor in case of LMN lesion. And we are not going to generally see profound atrophy and fasciculations in UMN lesion. We will see profound atrophy and fasciculations in LMN lesion. So the easiest way to remember this is, in UMN damage, everything goes up, means tone is increased, deep tendon reflex are increased, and the plantar is extensor going up. That is what we call as Babinski positive. In case of LMN lesion, lower motor neuron damage, everything is going low. Lower may everything low, upper may everything up. Tone is decreased, reflex is decreased, and plantar is going flexor downwards, right? So this way you can remember difference between LMN and UMN. Okay, that's something that you need to always know. So first we'll start with the myasthenia gravis as a proper disease from the neurology. What is it? Myasthenia gravis is a disease of the neuromuscular junction. What is it? It is a disease of neuromuscular junction. Neuromuscular junction primarily refers to the junction between the nerve terminal and the muscle. So in myasthenia gravis, this is, let us say, nerve terminal, and this is the muscle. This is the muscle. This is the lower motor neuron. Normally what happens, we release the acetylcholine from the nerve terminal. This acetylcholine will come and bind to its receptor, right? Let us say this is acetylcholine receptor. So this acetylcholine will come and bind and cause the contraction of the muscle. So in myasthenia gravis, we have created antibodies against this acetylcholine receptor. So they bind and block it, right? So this is affecting the nerve side of the neuromuscular junction or the muscle side? It is affecting the muscle side. So we can call it as, it is a disease of post-synaptic neuromuscular junction disorder, or you can say post-synaptic defect. Here it is, I can also call it as an autoimmune disorder. It is an autoimmune disorder because here we have antibodies. We have antibodies against, we have antibodies. Mainly the most common antibody we have is anti-acetylcholine receptor antibody. Anti-acetylcholine receptor antibody. We also have anti-muscle specific kinase antibody, and we have another antibody called as anti-lipoprotein 4 receptor antibody. But among them, the most common one is anti-acetylcholine receptor antibody. Any patient of myasthenia gravis who has this antibody positive, will call it as seropositive myasthenia gravis. Others are seronegative or double negative myasthenia gravis. Okay, and being an autoimmune disorder, this is more common in females than males. It is more common in females than males. Okay, so in terms of clinical features, the patient will present with weakness of muscles, which is characteristically having what we call as diurnal variation. Diurnal variation. What do I mean by that? The weakness is not constant throughout the day. In case of myasthenia gravis, the weakness goes on increasing as the day progresses. And in case of Lambert-Eaton, the weakness goes on decreasing as the day progresses. Okay. So now already we have discussed what are the antibodies present. We have anti-acetylcholine receptor antibody, and if this is positive, then we call that case of myasthenia gravis as seropositive myasthenia gravis. We can also have this anti-MuSK and anti-lipoprotein 4 receptor antibodies. Among them, it is the anti-lipoprotein 4 receptor antibody which is the least common antibody, and anti-acetylcholine receptor, as I've already told you, is the most common antibody. So here, because there is a competition happening between the antibodies and the acetylcholine, one after the other, muscles start losing the competition with the antibodies, and as the antibodies win, they bind to the receptor and block the action of the acetylcholine. So there's a sequential involvement of the muscles. The most common or the earliest muscle to get affected is levator palpebrae superioris. Levator palpebrae superioris is the earliest muscle to get affected, followed by the muscles of extraocular movement. Muscles of extraocular movement, followed by proximal muscles, followed by facial muscles. Facial muscles. So this results in a very peculiar disease progression, right? So this levator palpebrae superioris involvement results in ptosis, and once there is involvement of the muscles of extraocular movement, now patients start developing diplopia. So earliest manifestation of myasthenia gravis is ptosis followed by diplopia. Once there is involvement of proximal muscles, we will call it as proximal myopathy or proximal muscle weakness, and eventually there is involvement of facial muscles, so patient can have what we call as facial drooping. Facial drooping. Now if I have myasthenia gravis which is restricted to only eye, we will call it as ocular myasthenia gravis, but once proximal muscles and facial muscles are also involved, we will call it as generalized myasthenia gravis. So only this much affected, it is called as ocular myasthenia gravis, and everything involved we will call it as generalized myasthenia gravis. Generalized myasthenia gravis. Clear? Okay. Now in terms of investigation, there are n number of investigations that we can do. We will look at the MCQ side of it. So if they ask you what is the most sensitive investigation, that's an MCQ. They can ask you what is the most specific investigation. Okay. Then they can ask you what is the most commonly performed investigation. The most sensitive investigation is what we call as single fiber electromyography, where we have to repetitively stimulate a single muscle fiber and see what happens to its compound muscle action potential. In myasthenia gravis, the more muscle is used, goes on becoming more weak. That's why as the day progresses, the weakness increases in myasthenia gravis, right? So here in the single fiber electromyography, I'm getting what we call as decremental response. So the compound muscle action potential goes on decreasing with this repeated stimulation given to the muscle. In case of Lambert-Eaton and botulism, which are presynaptic neuromuscular junction disorders, we get the incremental response. We get the incremental response. Okay. The most specific investigation is going to be anti-acetylcholine receptor antibody. That's the surest sign that, okay, you have clinical features plus this antibody positive, you have myasthenia gravis. But what is the most commonly performed investigation? It is repetitive nerve stimulation test. It is nothing but an adaptation of the single fiber electromyography. FMGE is very cumbersome, complex, because you have to stimulate a single muscle fiber repetitively. Instead, you stimulate the whole muscle, then we call it as a repetitive nerve stimulation test, where of course you are going to get same, that is decremental response. Decremental response. Okay. Then if they ask you what is the screening test that you can do. So currently we consider ice pack test as the screening test. Ice pack test as the screening test. So what do we do here? We ask the patient to hold an ice pack on an eye with the ptosis, and after removing the ice pack, if the ptosis disappears, the test is positive. It is suggestive of myasthenia gravis. So ptosis improves on ice pack test. Okay. Then we have one more, which is your famous edrophonium or tensilon test. So what do we do in this test? We administer an acetylcholine esterase inhibitor. By inhibiting the acetylcholine breakdown, we increase the acetylcholine levels and improve the symptoms. So here also generally ptosis improves on administration of an acetylcholinesterase inhibitor like edrophonium. The point to note here is that it is not routinely performed due to risk of cholinergic crisis. This is not routinely performed due to risk of cholinergic crisis. Because we are giving an acetylcholinesterase inhibitor. So when we inhibit the acetylcholinesterase, we are not selectively inhibiting in the neuromuscular junctions of the skeletal muscles. It will also inhibit in the neuromuscular junctions of the autonomic nerve, the smooth muscles, and also the other autonomic nervous system. So it can mess up. We can have this classical cholinergic crisis when we give edrophonium or tensiron. That's why we are not routinely performing it. Okay. So now once I have diagnosed that it is a case of myasthenia gravis, can the patient die? Yes, the patients can die because of the respiratory paralysis, right? And of course, the symptoms are going to cause problem in their day-to-day life. So how do I manage? So primarily a stable myasthenia gravis patient is managed. Like let us say I'm dealing with a myasthenia gravis. If the patient has a respiratory paralysis, then we will call it as myasthenic crisis. Myasthenic crisis. So what is myasthenic crisis? Myasthenic crisis is where you have severe myasthenia gravis resulting in respiratory paralysis. So if the respiratory muscles are not able to work, what is the immediate next step in terms of management? First, you have to intubate the patient and put on the ventilatory support. Otherwise, by the time your drugs work, he will die. Second, all these antibodies which are competing with the acetylcholine for the receptors, they need to be removed from the body. So that we can do with plasma exchange or by giving IV immunoglobulins. But if I am dealing with a chronic stable case of myasthenia gravis, I don't need to do all this. I would rather try to increase the acetylcholine with the help of acetylcholinesterase inhibitor, and the drug of choice, acetylcholinesterase inhibitor for the myasthenia gravis, is going to be pyridostigmine. Pyridostigmine is the drug of choice. Donepezil is also an acetylcholinesterase inhibitor. That is a drug of choice for the Alzheimer's disease, right? And then decrease the antibodies. I can decrease the antibodies by steroids and immunosuppressants, by giving steroids and immunosuppressants like azathioprine. And one more thing we can consider here is thymectomy for seropositive myasthenia gravis. Seropositive means anti-acetylcholine receptor antibody positive cases, right? So this is a quick summary of the myasthenia gravis. Okay, so another extra point you have to remember here is that the Lambert-Eaton syndrome. So please remember, in Lambert-Eaton syndrome, you get single fiber electromyography or repetitive nerve stimulation test shows incremental response. Another condition where you get incremental response is botulism. Botulism also shows incremental response. Means the compound muscle action potential goes on increasing with the repetitive stimulation. Okay. So now let's quickly move to the next important topic from neuro, which is GB syndrome. Most of the questions from GB syndrome are simple and straightforward. All the examiner wants is that from the story, recognize that I'm talking about GB syndrome, and then they will ask some flat, simple questions following that. So what is GB syndrome? Very similar to acute rheumatic fever. So this is also an infection triggered autoimmune polyradiculoneuropathy. So when I say neuropathy, What am I referring to? Peripheral nerves. So this is a disease of the peripheral nerves, and peripheral nerves contain lower motor neuron. So this is a lower motor neuron disease. This is a lower motor neuron disease. So how will I recognize that this patient is talking about, the story is talking about the GB syndrome? So usually you will have this classical story of Campylobacter jejuni dysentery or diarrhea, followed by that patient will have rapidly progressing ascending paralysis, okay. And when I examine, because it is a disease of lower motor neuron, what will happen to tone? Tone will be decreased in the affected limbs. So we will have flaccidity. And what will happen to the reflexes? Because it is a lower motor neuron disease, reflexes will also be decreased. There will be hypo or a reflex, absent or diminished reflexes. Okay. Now what else I can do to confirm that I'm dealing with a case of the GB syndrome? The third point that can help me to diagnose a case of GB syndrome is that if I go for the CSF analysis, CSF shows what we call as albuminocytological dissociation. Albuminocytological dissociation. Now what do I mean by that? Normally what happens in meningitis, whenever we have meningitis, WBCs, lymphocytes, like cell count is increased. At the same time, protein is also increased. But here we have cell count not increasing much. Cell count remains less than 50, but there is significant increase in the CSF protein. So they are not separate. Normally both increase together. Here protein is increasing, cell count is not. We call it as albuminocytological dissociation. Okay. Then fifth, we can have nerve conduction study abnormalities. So anyone presenting with rapidly progressing ascending paralysis with flaccidity and absent or hyporeflexia with CSF showing albuminocytological dissociation or nerve conduction study showing abnormalities is suggestive of GB syndrome. And collectively, all these features put together, we call the criteria for diagnosis as Brighton's criteria. It's called as Brighton's criteria. Okay. Now, in terms of the management of a case of GB syndrome, you need to also know that, okay, we know that Campylobacter jejuni caused immune system to get activated, it caused damage to the nerves, and I ended up with all this problem. But there are subtypes, because the damage to nerves may cause damage to only axon or only myelin or both. Based on that, we have to subcategorize the GB syndrome into different types. This subcategorization based on nerve conduction study reports. So from the nerve conduction study, we get to know whether it is a demyelinating injury or whether it is the axonal injury, whether myelin sheath is removed or axon is also damaged or both are damaged. So based on that, GB syndrome is classified into, the most common type is called as AIDP, acute inflammatory demyelinating polyneuropathy. So this is a demyelination type. This is the most common type. And in these patients, when we do nerve conduction study, what point we notice? Myelin sheath is required for the rapid conduction of electrical impulses in the nerve. So if myelin is not there, the conduction velocity decreases. So nerve conduction study will show decreased conduction velocity. On the other hand, we have another type called as AMAN. AMAN stands for acute motor axonal neuropathy, and we have one more called as acute motor as well as sensory. Acute motor and sensory axonal neuropathy. So both of them, there is damage to axonal injury. So this is an axonal injury type. So in these patients, when we do nerve conduction study, the conduction velocity will be normal because they have the myelin. So conduction happens faster, but the voltage delivered to muscle is low. So we will have decreased compound muscle action potential. and we have a relatively less common variant which is called as GB syndrome, which is called as Miller-Fisher syndrome. Miller-Fisher syndrome. This Miller-Fisher syndrome is usually mixed. It's a mixed, means we have axonal injury as well as demyelination. It is mixed. Demyelination is more common than axonal injury. Okay, few points about the AIDP. AIDP is the most common type. Okay, and it generally carries good prognosis because it is easier to cause remyelination. After the remyelination happens easier. It carries good prognosis, and classically these patients are associated with an antibody which is called as anti-ganglioside M1 antibody, anti-GM1 antibody. Aman and Amsan generally carry poor prognosis because there is injury to the axons. They carry poor prognosis, and the antibody that is encountered in these patients is mainly anti-GD1 antibodies. Okay, now this Miller-Fisher, there are some peculiar points about Miller-Fisher. Miller-Fisher affects sensory neurons more than motor, so weakness is less common. What these patients predominantly develop, they will develop ataxia and they will have ophthalmoplegia, weakness of the extraocular muscle. So they can have ataxia and ophthalmoplegia. The antibody that I encounter in these patients is anti-GQ1B, and here also we would count it as good prognosis. The reason is sensory nerves are affected. When motor neurons are affected, muscle weakness, respiratory failure, death. Sensory neurons we can have ataxia, loss of sensations, but death risk is less. So generally it is carrying good prognosis. So MCQ wise they will ask you which GB syndrome variant is predominantly pure motor variant, which GB syndrome variant is associated with ataxia, right? So please remember, Aman is a pure motor variant. Aman is a pure motor variant. It's there in the name, right? What name says? Acute motor axonal neuropathy. Sensory neurons are not affected. In all other conditions, sensory neurons are affected. Okay. Now, how do I remember these antibodies? I have a simple way to make it easy for you to remember. When it comes to the three variants we discussed, right? This is a rare variant. This is the most common type. Okay. So in India, I would always say that we rarely follow queues, right? From airports to railway stations to bus stands to schools and colleges. We don't follow queue. So for the rare variant, queue is not followed, right? We rarely follow queue. So that we remember that rarely we follow queue. So for rare variant, we have GQ1 antibodies. The most common category when you write exams is general merit. So for the most common type, we have most common category, that is general merit. The one that is remaining now is anti-GD1 for the Aman and Amsan. Okay. So once we know the subtypes, we have a fair idea about the prognosis. Okay. Now coming to the final management or treatment. The main thing about the treatment of GB syndrome is that as the more and more nerves get damaged, we will have respiratory paralysis and the risk of death increases. So I don't want more nerves to be damaged. So what I should do, all these antibodies that are there in the patient's body, I want to get them off so that more nerves don't get damaged, respiratory muscles don't get affected, and he won't die. So for that, either I have to follow plasma pheresis or I can follow IV immunoglobulins, IVIG. Which one is better? IVIG is slightly superior. It is slightly superior to plasma pheresis. Slightly superior to plasma pheresis. Okay, so that's a quick take on the GB syndrome. In an MCQ based exam, how do I recognize it? If the examiner says patient had an episode of dysentery, after that he presented with rapidly progressing ascending paralysis, he mentions either flaccidity or absent reflexes, he is talking about GP syndrome. After that, he may ask what is the most common variant. Most common variant is AIDP, or he may ask which of the variant of this disease associated with ataxia. Think of Miller-Fisher. They may ask which one is predominantly a demyelinating variant. It is AIDP. They may ask which one is predominantly an axonal injury variant. That is Aman and AMSA, right? Okay. So next we'll go to stroke. Now, what are the questions that are usually asked on the stroke? Most questions from the stroke are regarding the decision about management. How would you manage this case of stroke? They give a story. They mention the time from the onset of the stroke to the presentation to the hospital, and then they will ask whether you will go for thrombolysis, whether you will go for mechanical thrombectomy, or whether you will go for conservative treatment, right? So we'll begin by first defining the stroke. So what is stroke? Stroke is defined as focal or global neurological dysfunction. When I say focal, some part of the brain. When I say global, all of the brain, going for dysfunction, neurological dysfunction of or due to some problem in the blood vessel, vascular dysfunction of vascular origin. So problem has to be in the blood vessel. Some blood vessel problem leading to brain's abnormal function, then it is stroke. If a tumor causes brain to lose function, it is not stroke. If trauma causes brain to lose function, it is not stroke, right? So what can go wrong with the blood vessel? Either it gets blocked, it causes ischemia infarct, or it ruptures and bleeds. So we can have ischemic stroke and hemorrhagic stroke, right? But these deficits should lasting for more than or equal to 24 hours or until death. So if patient develops death within 3-4 hours of some massive bleed in the brain, we'll still call it a stroke, because rest of the definition is like whole definition is satisfied. There is dysfunction of the brain because of a problem in the blood vessel, bleeding happened, but patient died. Until he died, the deficits were there, so then it is stroke only. Okay, but if the deficits improve within 24 hours, then we will call it as TIA, right? So neurodeficits improve within 24 hours without an objective evidence of infarct on imaging, then we call it as TIA. Both the definitions are very, very important. I want you to literally by heart. In fact, I'll give you a simple example. Like, let us take a question itself. This is exactly the same question which I'm recreating that had already appeared in one of the FMGE exam. So a 58-year-old presented with right hemiparesis, which improved to normalcy within 4 hours. CT brain at presentation to hospital showed left MCA infarct, and then that asked what is the diagnosis. Options available were 1 TIA, second ischemic stroke, the third one was hemorrhagic stroke, and the fourth one was no stroke or TIA. So what do you think should be the diagnosis here? Please apply the definitions, both of them. It's very, very important. That's why I'm taking some time to clear it. Most of the students had answered it as TIA because within 24 hours it showed improvement. But when you look closely at the definition, to call it as TIA, दो criteria meet होना चाहिए. जो deficits हैं, that should improve within 24 hours. And when I do imaging, there should be no infarct. When both the criteria are met, it is TIA. If symptoms improve within 24 hours, but there is still infarct, it is ischemic stroke. And if symptoms take more than 24 hours, but imaging shows nothing, it is still infarct. It's still an ischemic stroke. It's still stroke. It's not TIA. When both criteria is met, then only it is called as stroke. So here one criteria is not met. What is not met? There is evidence of infarct present. There should be no evidence, right? There should be no infarct visible on the CT scan. It's very, very important point. So here I can clearly see an infarct. So we will have to count it as an ischemic stroke. If they had mentioned that there was bleed visible on the CT, we would have called it as hemorrhagic stroke. So few points you have to remember here is that occurrence of TIA is associated with increased risk of stroke. Means this time he might have recovered from the deficit, but next time he may not recover. So many of them within a very short span of time will develop a full-blown stroke. So we have to assess the risk of stroke in patients with TIA. Risk of stroke in TIA assessed by, there is a score which is called as ABCD2 score. So again, just like how you need to remember the Duke's criteria, Revised-Jones criteria, similarly you have to also remember the ABCD2 score. Okay, so what are the components of this score? It's very easy to remember. It's a mnemonic in itself, where A stands for age. Okay, age more than or equal to 60 years, patient gets 1 point. B stands for blood pressure, more than 140/80, patient gets 1 point. ABCD2 ka C stands for clinical features. A patient has got one-sided weakness, that's hemiparesis, he will get 2 points. A patient gets any speech impairment without the weakness, means only Broca's aphasia, Wernicke's aphasia, but no weakness, he gets 1 point. Weakness is at 2 points during that episode of TIA. Okay. Then how long the weakness lasts or the symptoms last? If they last for more than 1 hour, 2 points. And if it lasts for 10 minutes to 59 minutes, 1 point. The last one is another D is diabetes. So if patient is diabetic, 1 point. So here it refers to A for age, B for blood pressure, C for clinical features, and D2, ABCD2. One D is duration of symptoms and the second one is diabetes, right? So totally we are giving 1 point for each parameters except 2. Duration more than 1 hour gets 2 points and unilateral weakness gets 2 points. For everything we give 1 point. So if the patient is having a score of 0 to 3, his risk of developing an obvious stroke within next 2 days is very low. But if it is 4 to 5, it is considered as moderate risk, and 6 to 7 is considered as high risk of stroke. Now there is a new parameter called as ABCD2I, where I stands for imaging, mostly MRI or CT. So if on MRI or CT some evidence of the infarction is there, we give 3 points. So ABCD2 totally carries maximum 7 points. 3 points can be added for imaging, which is a new modification. Otherwise conventional ABCD2 score is ABCD-D2. And point to note here is, when do you call it as high risk? When it is 6 to 7, we call it as high risk of stroke. Okay, clear? Now we will concentrate on the stroke part per se. Okay, so the stroke can be either hemorrhagic stroke or ischemic stroke. Those are the two abnormalities of the blood vessel, right? So it can be ischemic or hemorrhagic. Hemorrhagic surgery faculty will cover. From the hemorrhagic, primarily I want you to remember one thing, criteria called as ISH score. That's it. Okay. Ischemic is where you have to make a decision about thrombolysis versus mechanical thrombectomy versus conservative treatment. Okay. So let us talk about the ischemic stroke. Whenever we have a patient of stroke, early recognition is very, very important, because more late I recognize the stroke, more damage to the brain happens, and the chances of recovering the functions of the brain becomes less difficult. So how do I recognize the stroke early? For the early recognition of stroke by the layman, we have a protocol which is called as BFAST protocol. It is called as BFAST algorithm or the protocol. So what it says is, train the patient's attenders, means whoever is at risk of developing stroke, train their attenders to recognize stroke early by looking at these B fast parameters, where B stands for balance issues, E stands for eyesight issues, right? Abnormal vision, loss of vision. F stands for facial asymmetry, drooping of the face. A stands for weakness of the arm, one of the arm becoming weak. S stands for speech abnormalities, either not able to understand speech, not able to produce speech, slurring of speech, all those speech abnormalities. So when patients attenders notice any one of these happening to their kin or the patient, without wasting time, they should bring the patient to hospital. T here stands for time, right? This is for early recognition of the stroke by the layman. And for clinicians, we have one tool which helps us to early recognize the stroke, and that is called as Barry's sign or pronator drift sign. Pronator drift sign, or it's also called as Barry's sign. Barry's sign. So what is this? When you ask the patient to hold their upper limbs, both the arms outstretched in supine position, the weaker side will slowly start pronating and drifting down. This is what we call as pronator drift sign or Barry's sign. So once you know that, okay, you're suspecting this patient to be having stroke, attenders recognize it by these abnormalities, you recognize with the pronator drift sign. So you know that your patient has probably stroke. You don't still know whether it is ischemic stroke or hemorrhagic stroke. So once you recognize it as stroke, you need to differentiate whether it is ischemic or hemorrhagic. So for that, I have to image. So whenever you have a suspected stroke, we have to do imaging, and the investigation of choice for the imaging is going to be non-contrast CT. Non-contrast CT is not a good investigation when it comes to recognition of infarction, because infarct may not be evident for at least 6 hours after the infarction, and most patients present before that. But why is it still an investigation of choice? It's highly effective, highly sensitive for recognition of bleed. So when we do non-contrast CT, if there is bleed present, it doesn't miss the bleed easily. If the bleed is present, it is hemorrhagic stroke. It is hemorrhagic stroke. But if I don't have bleed, infarct is not there, but still, if there is no bleed, CT doesn't miss the bleed easily. So if there is no bleed, we will take it as ischemic stroke. So in the CT, if there is no bleed, we are dealing with ischemic stroke. So once I have a patient with ischemic stroke, how do I manage? Management of ischemic stroke. So when I have a patient with ischemic stroke, that means there is a blocked blood vessel. One of the blood vessel, let us say this is a blood vessel. There is a clot inside it. There is a blocked blood vessel. So the earlier I remove the blocked blood vessel, I will be able to save some part of the brain. So when this blood vessel get blocked, I will have some area of the brain where the blood supply is so critically low that that area becomes dead. The dead area, we'll call it as infarct. But there will also be a remaining area which is still getting some amount of blood supply, sufficient enough for it to survive but not sufficient enough to work. So that area we will call it as penumbra. So when I open this blocked blood vessel, blood flow gets re-established. This area is dead, I cannot recover it. But this area is dysfunctional, not dead. So if it gets blood supply, it will bounce back, it will get reactivated. So my goal of treatment is to reactivate this penumbra. So once a blood vessel is critically blocked, when this penumbra will become infarct, so the whole area gets converted to infarct by 24 hours. So after 24 hours, all the territory supplied by that particular blocked blood vessel will become infarct. To start with, some area dies, then little more. So infarct goes on expanding, penumbra goes on shrinking. By 24 hours, everything is gone. So if anyone who presents after 24 hours, opening this blood vessel makes no sense because the whole area will be infarct, right? But if they come before 24 hours, opening the blood vessel means I will be able to save at least some of the neurons from dying, right? So that's why the time of presentation after stroke onset is the single most important determinant how will I manage a case of stroke. If it is after 24 hours, then there is no point in doing any revascularization. We will directly go ahead with secondary prevention. This time, whatever stroke happened is done. I can't do anything about it. Your brain, some part is dead, not possible to recover, but at least I can try to prevent another episode of stroke from happening. So we'll call it a secondary prevention, for which we primarily use aspirin plus statins, right? Antiplatelets and statins. But if they present within 24 hours, we have two choices. Either I can give medications to dissolve this clot. This clot can be dissolved by medications. We will call it as thrombolytic agents. Or I can put a wire and pull this clot out. We will call it as mechanical thrombectomy. Mechanical thrombectomy is only possible when we have a clot in a large blood vessel. Thrombolysis is possible whether the clot is in small or large. So what we would prefer is try to do thrombolysis for all patients when they present to us, so that whether it is in the large or small, clot will get dissolved. After this, if it fails to dissolve and clot is in a large vessel, we can put a wire and try to remove. So again, when I can do this mechanical thrombolysis, it can be done only when patient presented within 6 hours. After 6 hours, the risk of bleeding increases, so I can't do thrombolysis. So if the patient presented within 6 hours, this is according to the latest edition of Harrison. The previous editions and according to guidelines, if the patient presented within 4.5 hours. So which one to choose? I leave it to you. I would prefer to consider, because examiners most likely go ahead with the Harrison's version rather than the guidelines, you can say 6 hours. So if the patient presented within 6 hours, first step is to go for thrombolysis. Thrombolysis. Okay. But if patient presents after 6 hours but before 24 hours. After 6 hours but before 24 hours. Thrombolysis cannot be done. It is not safe. But mechanical thrombectomy is still a possibility. But mechanical thrombectomy is only possible when the clot is there in a large blood vessel. So I have to do another investigation to see whether clot is there in small or large blood vessel. And that investigation is going to be CT angio. So if the CT angio shows that there is large vessel occlusion, there is large vessel occlusion. And when I say large vessel occlusion, I primarily refer to internal carotid artery, then M1 part of the middle cerebral artery, or proximal part of the anterior cerebral artery. So if the clot is there in these locations, we go ahead with what we call as mechanical thrombectomy. Mechanical thrombectomy. But if there is no clot at all, or the clot is there in the smaller blood vessels, in simple words, there is no large vessel occlusion, so then I can't do mechanical thrombectomy. I can't do thrombolysis either, because patient is presented after 6 hours. Clot is not there in a large vessel, so I cannot do mechanical thrombectomy also. So in that case, the treatment shifts to secondary prevention. So this stroke, nothing is possible for us to do. We can only try to prevent another episode of stroke from happening. Okay. Now these patients who had undergone thrombolysis, the success rate is 50%. Means 50% of these clots will dissolve. In 50% cases, clots fails to dissolve. In that case, what should I do? In that case, I can still try to remove it with a wire, right? So after the thrombolysis, again we have to join this step. The story is not over if you have done thrombolysis. After thrombolysis, you have to do CT angio. After CT angio, clot is still visible in a large blood vessel, you go for mechanical thrombectomy. No large vessel occlusion, then follow up with the secondary prevention. So I want you to literally memorize this protocol, because around this we are expecting MCQs. Okay. From pharmacology, I also want you to study the drugs used for thrombolysis, their calculation of the dose, and indications, contraindication. That is an important MCQ zone. Sir has already covered in pharmacology, so I'm not going to reiterate again here. But this is a protocol that I want you to by heart. It's a very simplified approach. So if you just memorize that, okay, I got a patient with stroke in the emergency room. First thing I will ask is when the symptoms started. Patient or attender say that, sir, yesterday, more than 24 hours, only secondary prevention. They say within 24 hours, then we have to follow the rest of the protocol. So within 24 hours, okay, is it within 6 hours? Yes. Then I will go ahead with thrombolysis. After thrombolysis, I will go for a CT angio. If it is after 6 hours, then thrombolysis is out. I will go ahead with CT angio. If there is a large vessel occlusion, I will go for mechanical thrombectomy. Okay, so that's going to be the approach. So that's about the important neuro topics. So from here we will move to the important nephro topics. From the nephrology, ABG and AKI, CKD, these are the three important topics. Apart from that, glomerular diseases is an important topic, but mostly questions come from pathology side of it, with some clinical story and then a lot of pathological information available. So I will concentrate on the medicine side of it. Okay, so first is ABG. In the ABG, what do they ask you? Simple questions are like diagnose whether it is metabolic acidosis or respiratory acidosis, metabolic alkalosis, respiratory alkalosis. Second question, if it is metabolic acidosis, they will ask you to calculate the anion gap, and they will ask you what are the causes for high anion gap and low anion gap metabolic acidosis. So to answer the ABG, we need to know few important parameters. What are those? We will take an example and understand. Let us take an example or a ABG problem to solve. An example or a ABG problem to solve. So here I have a patient whose pH is, let us say, 7.1, and then his partial pressure of oxygen is 50 millimeters of mercury. His partial pressure of carbon dioxide is, let us say, 20 millimeters of mercury, and his bicarbonate level is 10 millimoles per liter or milliequivalents per liter. His serum sodium levels are 148 millimoles per liter, and his chloride is 100 millimoles per liter. So this is all information available to me. Now how do I diagnose it? So in the ABG, means we are primarily looking at acid-base disorders. We have to look at pH, right? That is one thing that will help us to decide acidosis versus alkalosis, and then we have to decide whether it is metabolic or respiratory. So in the body, the normal pH range, we have a normal range of the pH which varies from 7.35 to 7.45. So this range we will count it as normal, and when pH is more than 7.45, we will count it as alkalosis, and when it is less than 7.35, we will count it as acidosis. So in this ABG, we know that this is acidosis, pH is less than 7.35. Now how body regulates this pH? Body tries to regulate the pH by balancing the acids and bases. So what are the major acid in the body and what is the major base? The major base in the body is bicarbonate. Bicarbonate is the major base. There are so many acids in the body, but for the simplicity of dealing with ABG questions, I want you to remember major acid in the body is carbon dioxide. You might be thinking, sir, how? Carbon dioxide, when dissolved in water, becomes carbonic acid, which is an acid. Okay. There are other bases, other buffer system, there are other acids produced in the body, but for us to understand ABG, this is more than enough. Okay. Now, any condition where base increases, what will happen to the pH? pH will tilt towards alkalosis. Any condition where acid increases, pH will tilt towards acidosis. But at the same time, acid or base does not increase, one of them decreases. If base decreases, what will happen to the pH? Acid and base together are maintaining the pH. If base decreases, acid is more in a relations, so pH tilts towards acidosis, or vice versa is true. Any condition where acid decreases, base is now more in comparison to acid, so pH tilts towards alkalosis. So altering the acid or base results in pH tilting towards acidosis or alkalosis. Clear? Okay. Now, whenever acid increases, where pH is tilting towards acidosis. So now if I have to compensate it by altering the base, what should I do to the base? Acid is increased, because of that pH is becoming acidotic. So now I want to get the pH back to normal. So what should I do? Let us say that we are looking at a balance. Okay, acid and base. Increasing acid has tilted the pH to acidosis. So what should I do now to get the balance back to normal? Should I increase the base or should I decrease the base? Acid increased, pH is acidotic. So now I have to neutralize that acid by increasing the base. So this we call it as compensation. Compensation always follows the direction of the primary abnormality. तो अगर primary abnormality acid का increase होना है तो compensation होगा base का भी increase होना. So what do I learn here? If acid is increasing, base has to increase. That's a compensatory response. If base is decreasing, acid has to decrease. So in other words, normal ECG, if carbon dioxide increases, bicarbonate will increase to compensate. If carbon dioxide decreases, bicarbonate will decrease to compensate. If bicarbonate increases, carbon dioxide will increase to compensate. This is what we call as compensation. So the direction of compensation is same as the primary pathology. जो भी मेन प्रॉब्लम है उसी के डायरेक्शन में कॉम्पेंसेशन भी जाएगा, सो दैट द बैलेंस गेट्स नॉर्मलाइज्ड. अगर एसिड इंक्रीज हो रहा है और बेस डिक्रीज होगा तो पीएच और नीचे हो जाएगा, राइट. सो प्राइमरी एब्नॉर्मलिटी कॉम्पेंसेशन ऑलवेज फॉलो द सेम डायरेक्शन. नाउ लेट अस टेक दिस एग्जांपल कि हाँ एसिड इंक्रीज हो रहा था तो दैट वाज माय प्राइमरी प्रॉब्लम. सो टू कॉम्पेंसेट दैट बेस इंक्रीज्ड. अगर बेस इंक्रीज होके पीएच को नॉर्मल रेंज के अंदर लेके आता है, तो देन वी विल कॉल इट एज फुल्ली कॉम्पेंसेटेड. और अगर पीएच को नॉर्मल रेंज के अंदर लेके नहीं आ सकता है देन वी विल कॉल इट एज पार्शियली कॉम्पेंसेटेड. ओके, सो इफ increasing acid has resulted in acidosis and base increased and pH came back to normal, then we will say it is fully compensated acid base disorder. लेकिन increasing acid caused acidosis, increasing base pushed it little back but still not in the normal range, then we will call it as partially compensated. Clear? So we'll apply that concept. First, this ABC example, we will decide whether it is acidosis or alkalosis. Right? So what do you think it is? pH is less than 7.35. So that means here we are dealing with acidosis. Okay. The second thing after acidosis, I have to see whether it is a respiratory system pathology or the metabolic or kidney pathology. So for that we follow the ROMS or ROM criteria, which stands for respiratory opposite, metabolic same side. Right? Respiratory opposite, metabolic same side. Now what do I mean by that? We are primarily looking at the direction of pH and partial pressure of carbon dioxide. We are looking at the direction of pH and partial pressure of carbon dioxide. If both of them are in the opposite direction, मतलब pH increase हुआ है, carbon dioxide decrease, they are in the opposite direction, तो जो भी abnormality है वो respiratory है. If both are in the same direction, कि हाँ pH भी increase है and carbon dioxide भी increase है, both are in the same direction, same side, then it is metabolic. Metabolic same side, respiratory opposite side. So let us apply that here. So what is happening to the carbon dioxide here? pH is of course decreased. pH का direction नीचे है. Carbon dioxide का क्या है? Normal carbon dioxide value is 35 to 45 millimeters of mercury. So that is also decreased. So दोनों का direction same है. So applying the ROMS criteria, it becomes acidosis, which is metabolic. So we are dealing with metabolic acidosis. Metabolic acidosis में primary abnormality क्या होता है? बाइकार्बोनेट का डिक्रीज होना. So यहाँ पे primary abnormality क्या है? Metabolic acidosis में decreased bicarbonate. So compensation क्या होना चाहिए? If bicarbonate is decreased, carbon dioxide should also decrease. They always follow the same direction. So compensation is there. Carbon dioxide is decreased, as we just saw. Decrease in the partial pressure of carbon dioxide. So that means there is compensation happening. But is the pH back to normal because of this? हाँ, bicarbonate decrease हुआ, acidosis हुआ, और फिर respiratory system ने carbon dioxide clear करके balance करने की कोशिश की. But is the balance successful? No. pH is still low. Balance is not successful. So pH not fully normal. So what does that mean? I am dealing with a partially compensated metabolic acidosis. So we are dealing with a partially compensated metabolic acidosis. So that is the final diagnosis. This can also be called as metabolic acidosis with compensatory respiratory alkalosis. Okay, clear? Now, once I have recognized that it is this kind of a disorder, metabolic, respiratory, we have one more step involved. Whenever we are dealing with metabolic acidosis, we have to also calculate the anion gap. Anion gap. So what is this anion gap? Normally body has negative and positive ions. Positive ions are cations, negative ions are anions. They are in equal number. Anions and cations are equal in number in the body. But we don't measure both of them. All of them are not measured. We measure some anions, some cations. So that creates a gap between the two. Actually, there is no gap in the body, but we are not measuring everything. So that's why we get this gap. So this gap is measured by the difference between measured cations minus measured anions. Measured cations minus measured anions. And what are the measured cations in the body? It is mainly sodium and potassium. So we will only take into account sodium because Indian exams primarily focus on sodium. So sodium is my major cation. And what are the major anions? The negative ions, we have bicarbonate and chloride So this difference is what we call as anion gap. The normal anion gap is 8 to 12 millimoles per liter. So when it is more than anion gap more than 12 millimoles per liter, we can call it as high anion gap metabolic acidosis. And whenever we have the metabolic acidosis with the anion gap less than 12, we will call it as anion gap less than 12, we will call it as NAGMA or non-anion gap metabolic acidosis. So they repeatedly ask you, like they give an ABG, from there you make a diagnosis that हाँ sir anion gap तो ज़्यादा है तो ये high anion gap metabolic acidosis है. Then they will ask you which of the following is not likely to be the cause. So they will mention 3 high anion gap metabolic acidosis conditions and 1 non-anion gap metabolic acidosis. So how do I remember the causes for high anion gap metabolic acidosis? So for high anion gap metabolic acidosis, we have a simple mnemonic. Most commonly the mnemonic that students follow is what we call as mud piles, where M stands for methanol, U for urea, D for diabetic ketoacidosis, P for the drugs like fenformin and paraldehyde, I for INH and iron, L for lactic acid, E for ethanol and ethylene glycol, and S for salicylates. You may say, sir, still it is difficult to remember. The point to remember here is in high anion gap metabolic acidosis, an extra acid gets created or added to body. That's why the anion gap expands. So in methanol, an extra acid is being added, methanol poisoning. Uremia, extra urea is being added. Diabetic ketoacidosis, ketone bodies, acetone and other ketone bodies which are acidic in nature are added. Right? Lactic acidosis, lactic acid is added extra. Salicylic acid is added extra. So when an extraneous substance gets added to body and you get acidosis, it's most likely going to be high anion gap metabolic acidosis. There's another mnemonic that is gold mart. It's same thing expressed differently. Whichever works for you, you can follow. Okay. And then what are the causes for non-anion gap metabolic acidosis? You can remember with the mnemonic used part. The mnemonic is used part. Used part, where U stands for urinary diversion, S for small bowel fistula, E for extra chloride, D for diarrhea, P for pancreatic fistula, A for Addison's disease and use of acetazolamide, R for renal tubular acidosis, and T for drugs like tenofovir and topiramate. One important thing you have to remember here is mainly this renal tubular acidosis. You have different types of renal tubular acidosis. All the types of renal tubular acidosis are non-anion gap metabolic acidosis. So particularly diabetics get the distal renal tubular acidosis and they also get the diabetic ketoacidosis. So if you have HAGMA, high anion gap metabolic acidosis, it is DK. If you have diabetic and non-anion gap metabolic acidosis, it is mostly renal tubular acidosis. Clear? So that's going to be your approach to follow for the ABGs. We will take one more example before we move forward. Let us take it as a question. So ABG report is given to you where pH is 7.30, PaCO2 is 30 millimeters of mercury, then bicarbonate is 12 millimoles per liter. Okay, then sodium is, let us say, 140 millimoles per liter, and chloride is 110 millimoles per liter, right? So they're asking what is the diagnosis. So one of the option is respiratory acidosis. Second option is metabolic alkalosis. Third option is high anion gap metabolic acidosis. Last option is non-anion gap metabolic acidosis. So how are we going to approach this now? So we'll start with first looking at the pH, right? That's our approach. pH to decide acidosis or alkalosis. So what is happening to the pH? It is less than 7.35. So that means I'm dealing with acidosis for sure. After that, we will apply the ROMs to decide whether it is respiratory or metabolic. So here pH is decreased and PaCO2 normal is 35 to 45. It is less than that, so it is decreased. So both are in the same direction. So we're dealing with acidosis, which is metabolic. So our other options like the metabolic alkalosis and respiratory acidosis are ruled out. So now I am left with high anion gap metabolic acidosis and non-anion gap metabolic acidosis. So now I have to calculate the anion gap. So how do I calculate anion gap? The major cation is sodium. Sodium is 140. Sodium minus chloride plus bicarbonate together. So sodium is 140 minus chloride is 110, bicarbonate is 12. So that becomes 140 minus 122. So anion gap is equal to 18. So what is the diagnosis here? So final diagnosis turns out to be high anion gap metabolic acidosis. So this can be any of those conditions which we counted as high anion gap metabolic acidosis, like the mnemonic med piles, methanol, right? Uremia, diabetic ketoacidosis, lactic acidosis. Those are the possibles. You can take this example and calculate the anion gap for this question as well. Okay. So from there, we will now quickly move to the acute kidney injury, which is another important topic from the nephrology. What questions are asked? Primarily, questions are asked about the causes for AKI, like the pre-renal, renal versus post-renal, definition of AKI, stages of AKI, and some complications, right? So AKI is defined as, right? What is the criteria for calling it as acute kidney injury? The criteria is increase in serum creat by more than or equal to 0.3 milligrams per deciliter over baseline within 48 hours. What do I mean by this? Let us say there was an individual whose creatinine was 1 milligrams per deciliter, and then it has become 1.4 milligrams per deciliter. So how much increase has happened? Increase is 0.4 milligrams per deciliter. So if this much increase has happened within 48 hours, like I got it done yesterday, it was 1, today it is 1.4. So within 48 hours, it has jumped by more than 0.3 milligrams per deciliter. Then it will be called as acute kidney injury. So that is one parameter. But in many conditions, the rise happens very slowly. So in such cases, we have another criteria for that. So if serum creatinine, increase in serum creat by 1.5 times 1.5x or 1.5 times the baseline within 7 days or 1 week. Let us say that patient's initial creatinine was 2, which is high, I agree. It was 2 and it becomes 3.1 over a period of, let us say, 5 days, which is less than 7 days or 1 week. Should it be considered as AKI? Yes. From 2 to 3.1, how much jump has happened? 2 to 3 is 1.5 times, right? 2 into 1.5 is 3. It is more than 1.5 times from the baseline, and that has happened within 7 days. So this patient will be called as having AKI. Then in many conditions, you will not see the rise in the creatinine, but the urine output comes down. So we'll also have a criteria for urine output. So the urine output less than 0.5 ml per kg per hour for more than or equal to 6 hours. So for 6 hours or more, the urine output remains less than 0.5 ml per kg per hour, then it is considered as AKI. Now, what are the causes for the acute kidney injury? We will classify the causes into pre-renal, renal and post-renal. We will classify it as pre-renal, renal and post-renal. The causes will be classified as pre-renal, renal and post-renal. So when we say pre-renal, kidneys are fine, but the blood delivered to kidney is less, and that's why they are not going to function. Pre-renal AKI is the most common cause for acute kidney injuries. It is due to decreased renal perfusion. Decreased renal perfusion. So this can happen as in cases of patients with shock or hypotension. Shock or hypotension, which can be because of blood loss, trauma, sepsis, whatever. Right? Whenever there is decrease in BP or decreased perfusion of the kidneys, you can have, or it can happen in renal artery stenosis. Renal artery stenosis. Kidneys are fine, but arteries are narrowed. They are not able to deliver the blood. Right? That's another condition. Okay. Then we have renal, which is also called as intrinsic renal, and then we have post-renal. Post-renal is where you have the blood supply to kidney is fine, kidney is working fine, producing urine, but then the exit is difficult because of the blocks in the ureter or the bladder, especially bilateral blocks. So it could be because of ureteric or urethral obstruction. Okay. Now the renal can be further classified as acute tubular necrosis, glomerular disorders and interstitial nephritis. Interstitial nephritis. Okay. So what happens in, like, when you look at the nephron, it has a glomerulus, right? Upper and different arterial glomerulus, renal tubules, and surrounding there is connective tissue. So the renal AKI, kidney injury, means damage can be glomeruli, that is glomerular disorders, like your post-streptococcal glomerulonephritis, drug-induced glomerular injury and all. The injury can be to the renal tubules, PCT, DCT and all, that is acute tubular necrosis. Or the injury can be to the surrounding connective tissue. So we can categorize them into 3. Okay. Glomerular disorders includes example post-streptococcal glomerulonephritis, a classical example. Okay. Interstitial nephritis, the most common cause for the interstitial nephritis is drug allergy, mainly to antibiotics. Okay. Acute tubular necrosis can be due to drugs, or it can be acute pre-renal AKI itself can lead to acute tubular necrosis. Okay. Examiners do ask you to differentiate between pre-renal AKI versus the acute tubular necrosis. I will address that. But before that, staging of the AKI according to what we call as KDIGO criteria. So staging of AKI, we will have 3 stages. For that, we will look at urine output and serum creat. Urine output, how did we define it as AKI? Either 0.3 milligrams or higher jump in the creatinine from the baseline value, or 1.5 times the creat has become from the baseline value. And the urine output wise, urine output less than 0.5 ml per kg per hour for 6 hours. Remember this. We are using the same thing for the categorization. So when the serum creatinine increases from 1.5 is the cutoff to call it as AKI. So 1.5 to 1.9 times the baseline, we will call it as stage 1. Then 2 to 2.9 times the baseline, we will call it as stage 2. And more than 3 times the baseline, or serum creat reaching more than 4 milligrams per deciliter regardless of what was the previous baseline, or if the patient is started on the dialysis, that is renal replacement therapy, or if the GFR is less than 35 millimeters ml per minute per 1.73 meter square body surface area, we will call it as stage 3. So point to remember here is any patient where dialysis is started is stage 3 AKI. If it is AKI and we start dialysis, regardless of creat and other parameters, it is stage 3. Okay. And in terms of urine output, less than 0.5 ml per kg per hour for 6 hours, we call it as AKI. 6 to 12 hours will be called as stage 1. Okay. But if it is staying low for more than 12 hours, it is called as stage 2. And if it is less than 0.3, not 0.5, even low, less than 0.3 per kg per hour for 24 hours or more, or urine output is less than 100, that is anuria, for 12 hours, we will call it as stage 3. Okay. So this is one more thing you need to remember. So you need to remember the criteria. You need to memorize the table for the stages. You should be aware of the causes for pre-renal, renal and post-renal. And then you should know how to differentiate between the pre-renal AKI and renal, mainly API. So the parameter that is most important is FeNA. What is FeNA? Okay, so please remember, when kidneys function, how do they work? First, there is filtration happening at the level of glomeruli. We filter, right? This is what we call as glomerular filtrate. And then from the filter, we reabsorb all the necessary components that body needs, like water, sodium, potassium, all of that we reabsorb. And unwanted, we excrete in the urine. So under the condition where the perfusion of the kidneys is low, in pre-renal, amount of blood coming to kidney is low. In such cases, what should I do to the sodium? And what should I do to the water? Should I reabsorb most of the sodium and water when my BP is low, or should I lose most of the sodium and water in the urine? Of course, we will reabsorb. So basically what happens is, when BP decreases, there is activation of what we call as RAS. And in the RAS, we have one thing called as aldosterone. Aldosterone will stimulate us to reabsorb more sodium and water. And that increased reabsorption of sodium and water means what? The amount of sodium and water excreted will be less in case of pre-renal AKI, where the BP is low. But in case of, like, where is the reabsorption happening? Reabsorption is happening at the tubules. So if these tubules are damaged, I may not be able to reabsorb. So I will end up losing most of the sodium and water, right? So 2 points to remember: sodium and water, maximum reabsorption in pre-renal, maximum loss in acute tubular necrosis. So this sodium reabsorption can be estimated with a thing called as fractional excretion of sodium. We will call it as fractional excretion of sodium. So if the fractional excretion of sodium is less than 1%, means I'm excreting less than 1%, I'm excreting, most of it I'm reabsorbing. It is suggestive of pre-renal AKI. It is suggestive of pre-renal AKI. And if the fractional excretion of sodium is more than 2%, it is highly suggestive of acute tubular necrosis. I'm not able to reabsorb, I'm losing a lot. Then we will call it as acute tubular necrosis. Another point is, in case of acute tubular necrosis, because tubules is where reabsorption happens, I'm not reabsorbing, I'm losing most of the sodium and water. So I may have polyuria, and in these conditions I may have oliguria, because I am reabsorbing most of the water, I'm excreting less. So in case of pre-renal AKI, one more thing, because I'm excreting concentrated urine, I will have high urine osmolality, because the urine is highly concentrated, water is all reabsorbed. And in case of the acute tubular necrosis, the urine will be dilute, right? So I will have low urine specific gravity and low urine osmolality. right? So that explains how we can differentiate. The main thing that I want you to remember is the the main thing that will help you to differentiate is this FeNA. So FeNA less than 1%, think of the prerenal AKI. FeNA more than 2%, think of acute tubular necrosis. Okay, so that completes our discussion on the acute kidney injury. Okay, so I'm running through little technical issues. So probably we will do one more session where we will cover the CKD and the other rheumatic and gastric topics. I will let you know when the schedule gets fixed, and I will continue with the discussion further because my laptop is almost dying down, so I may not be able to continue the session. If you want any specific topics to be included, let me know so that I can cover those topics as well in the next session. So for today's session, I will wind up here. This notes of this workbook will be shared on the Telegram of the Physics Wala method, where you can download it and go through it for the revision. Before the next session, if you can quickly revise some questions from the nephrology and rheumatology, it will help you to learn quickly in the next session as well, right? So that's it for today. I'll see you in the next session, which will be updated to you on the Telegram soon. Until then, have a good time and study well. Make sure you do a focused revision and you're not going here and there haphazardly. Okay, Harsh Rawat, I will include the MI and arrhythmias in the next session. Sure. Yeah. Okay. See you guys. See you soon. Bye-bye.